Yeah, stand behind.
All right, it's ready to go. Thank you.
You're welcome. Okay, we're going to go ahead and get started with the first post-lunch presentation. A quick introduction here for Dr. Matthew Miller. Dr. Miller completed his undergraduate studies in PharmD from Texas Tech University, then went on to complete a PGY1 residency at Parkland Hospital in Dallas, Texas, and PGY2 infectious diseases residency at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences. He now serves as the infectious diseases clinical pharmacy specialist and antimicrobial stewardship co-chair at the University of Colorado Hospital. His interest areas include infections among immunocompromised hosts, gram-negative resistance, antimicrobial PK-PD relationships, and antimicrobial stewardship. Please welcome Dr. Matthew Miller.
Hi, everybody. Thank you for coming out today, and all of you on Zoom, thank you for listening in. Today we're going to be talking about updates in the management of urinary tract infections. There are some audience response questions that'll be through Kahoot. It looked like it's a different code than I put on the slide the other day, so disregard this code. When we get to that question, I'll pull up Kahoot and you can use the code that will be listed there to log in and participate in the questions as we go along. I have no relevant disclosures for this presentation. Here are some objectives that we will get through today: identifying current epidemiology and antibiotic prescribing habits for UTIs, and some of the collateral damage from unnecessary prescribing of antibiotics in the treatment of asymptomatic bacteria or non-bacterial causes of infection. Explore opportunities in UTI antibiotic stewardship through appropriate diagnosis and treatment. Discuss some preventative strategies, and then provided clinical scenarios, construct an appropriate treatment plan. I usually like to start off a lot of my talks with this slide. I think it's very relevant even today. This is Sir Alexander Fleming. You may remember him as the father of penicillin, discovered penicillin, and it's interesting, he made this he kind of foresaw what was to come nowadays with the advent of penicillin, and that, you know, we're foolish to think that it's eventually going to become resistant, and we need to be judicious users of antimicrobials because they're life-saving medications, and that inappropriate use will breed resistance, and then we'll be in a lot of trouble. So, additionally, that kind of brings us to this slide, and in the late 1930s. It was kind of the magic bullet of that time, and since then we have seen lots of antibiotics come and go, and their impact on our patients and survival have been significant, and the availability of antibiotics has led us to advances in different areas of medicine, such as cancer, chemotherapy, surgery, transplantation, obstetrics, and management of autoimmune and rheumatic disorders. So antibiotics are very important to the way we practice medicine today, and we need to be conservationists and stewards of these important medications for years going forward, so that we make sure that future generations have the same luxury that we do today. So, how are antibiotics currently being prescribed? In the ambulatory side, this is a 2015 publication pulled from CDC, and they estimated back then it was about 270 million prescriptions the way that, for antibiotics per year dispensed from outpatient pharmacies. This is enough to treat 80% of the U.S. population at least once per year with antibiotic courses. So this is a lot of antibiotics being prescribed. The CDC estimates that anywhere from 30 to 50% of ambulatory prescriptions are prescribed inappropriately or unnecessarily for non-bacterial infections. And so this is a lot of unnecessary antibiotic prescriptions in the millions, a lot of costs, a lot of side effects. And so need to be judicious with our use. The second table here is a table looking at who are the more common ambulatory prescribers of antibiotics, and most commonly family practice physicians, PAs, nurse practitioners, internal medicine, and pediatrics are kind of the predominant users of antibiotics in the ambulatory care setting. Inpatient, we don't do much better either. At least 1 out of every 2 patients that's admitted to the hospital receives at least 1 antibiotic from estimations from the CDC, with at least 30% of these antibiotics being prescribed inappropriately or unnecessarily for things that aren't of bacterial etiology or for excessive durations of therapy or duplication of therapy. And so there's a lot of reasons why antibiotics aren't indicated, but about 30% of inpatient use is unnecessary. And this hasn't really changed in the last, at least between 2006 and 2012. We haven't seen a huge shift in antibiotic prescribing, although I would congratulate everybody. There has been significant improvement and formation of antimicrobial stewardship committees nationally, and we've seen a lot of increase in those programs. And so expect, hopefully, as years go on, we'll start to see appropriateness of antibiotics improve. And as stewardship starts impacting and moving into the outpatient and ambulatory care settings, we'll also see some of those practice shifts as well. The other interesting thing here is in this time frame, they saw significantly increased use of vancomycin and carbapenems, which is a little scary. One, because carbapenems are kind of our last line of defense, although we have some newer agents that Katie Shahade is probably going to talk to you about a little bit later this afternoon, or has already talked to you about, actually, sorry. But the vancomycin also is out of proportion to the rates of MRSA in the U.S. The rates of MRSA are actually appear to be on a slow decline. And looking at our use, vancomycin is one of the #1 antibiotics prescribed at our hospital and definitely doesn't fit the epidemiology of MRSA, with only 30% of our Staph aureus being MRSA. So one of our targets moving forward in the next foreseeable future to try and combat overuse of vancomycin. That's a different topic. How are antibiotics being used? What are they being used for? And you can really break it down to the 3 most common infections, and this is true both in the ambulatory and inpatient side. About 75% of antibiotics are prescribed for one of 3 indications: respiratory tract, UTIs, and skin and soft tissue. And this is where I kind of start going into the UTI piece of this presentation, is that, about 20% or more of our prescribing is for urinary tract infections. And so this is a common infection that's seen both ambulatory and inpatient, and a huge place where we can impact antibiotic prescribing and be better stewards. So this is a recent publication from Open Forum Infectious Disease that looked at the impact of the 2011 IDSI guidelines. So they looked at the 2 years before the guidelines came out and the 2 years after to see kind of what changed in the prescribing patterns for otherwise young, healthy ambulatory women with uncomplicated UTI. And they looked at commercial prescription insurance to identify prescriptions for antibiotics, and also looked at codes for uncomplicated UTI, and they found about 650,000 women who met the criteria from emergency departments. And despite they showed a significant decrease, statistically significant decrease in the number of fluoroquinolone prescriptions, fluoroquinolones were still the most common antibiotic prescribed. It went from 44 to 41%. So that was statistically significant, but you might say that that may not be as clinically significant as we would have hoped, since for uncomplicated cystitis, the IDSA guidelines did not routinely recommend quinolones as first-line therapy for the vast majority of patients. Nitrofurantoin, fosfomycin, pivmenicillin were kind of the 3 agents that they identified. Unfortunately, we don't have pivmenicillin, so we can't really use that rec, but macrobid and fosfomycin, as you can see here, really didn't see any significant change. 20 for macrobid. And then despite this recommendation and from the guidelines, the duration of therapy should only be about 3 to 5 days, 5 days more for the macrobid, but 3 days for Bactrim quinolones. They saw that over 75% of the durations were for non-recommended durations, with majority of them getting more than 3 days of antibiotics. So this was significant finding and showing that even though we had guidelines that made good recommendations, the uptake of this was not as good as we had hoped it would be. And there's still a lot of unnecessary quinolone use, as well as excessive durations of therapy for otherwise uncomplicated cystitis. Then you may ask yourself, well, why should I really care about this? And I think most of you are in this room because you want to do better and improve your practice around antibiotic prescribing. And so you probably are aware of what's the potential downsides of excessive antibiotic use and overprescribing of antibiotics. And the big thing that stands out is resistance. Over the last decade or 2 decades, we've seen significant increase in fluoroquinolone resistance and third-generation cephalosporin resistance in our E. coli and Klebsiella. And then additionally, I put this on here because it's Kleb, you see that we're starting to see more and more resistance to carbapenems as kind of being thought of our last line of defense in some of these infections. So seeing lots of resistance. Fortunately, here in Colorado, at least from our antibiograms, we're not seeing as much as other places around the country that have much more problems with these types of infections. Additionally to resistance is side effects from unnecessary antibiotic use. Recent studies have come out and showed that antibiotic are the number 2 reason that people come to the ED for a medication-related side effect. This was right behind anticoagulants. It was the number 3 reason for hospital admission for side effects behind anticoagulants and hypoglycemic agents or anti-diabetic agents. And then the other big thing that we're all very well aware of is C. difficile infection. Antibiotics are probably the number 1 driver for C. diff infection. C. diff infection are associated with significant morbidity and mortality. And then with all of this, we see excess costs both to healthcare, the patients, and society at large. So antibiotics may be viewed as being benign, but they're not as benign as many people may think they are, and they're associated with a lot of adverse outcomes, and so we need to use them appropriately. And so with this, I'll kind of jump into UTI and with a question and get off my soapbox about antibiotic stewardship. So this is the first question, and I'm going to read the question and then back out to Kahoot so everybody can have a chance to log in. But this is an 89-year-old female, past medical history with dementia, cardiovascular disease, osteoporosis, and COPD, admitted with altered mental status and failure to thrive. Admission blood cultures grew Enterococcus faecalis. ID was consulted, and this was most likely felt to be due to biliary tract disease. Imaging result showed some sludging and some potential stones there. Patient was placed on IV ampicillin. A UA that was ordered on admission was positive for pus 11 to 30 whites, and then a urine culture that was obtained was positive for Enterobacter cloacae. However, patient had no localizing symptoms of infection for a urinary tract infection at the time. Oh, hopefully I can... bear with it. All right, code is 6993879. Give a little bit for everybody to log in who wants to participate. All right, I'm going to go ahead and it looks good. So based on that story and description, what antibiotics would you recommend for this patient? Add Bactrim for 7 days, add Cipro for 3 days, no antibiotics are necessary, change ampicillin to imipenem because it'll cover both the Enterococcus as well as the Enterobacter. All right, most everybody got that correct. The correct answer here is no antibiotics. Patient didn't have localizing symptoms, was improving on IV ampicillin for the Enterococcus bacteremia, likely just asymptomatic bacteriuria. She was monitored and never had any symptoms or worsening of her infectious, her white count or fever. So did good without antibiotics. Perfect. All right, we'll go back. All right, so next section, we'll talk a little bit about diagnosis, starting off with epidemiology of urinary tract infections. It's one of the most common infections. There's upwards of 10 million ambulatory visits per year for urinary tract infections. Very common among female patients. About 50% of females have at least one UTI in their lifetime, with an annual incidence around 13%. Adult male patients, UTIs are relatively uncommon with an incidence about a tenth of females, about 3%, or sorry, not a tenth, but about 3%. And usually this is associated with structural functional abnormalities and advancing age related to prostate health issues. In terms of hospitalized urinary tract infections or nosocomial UTIs, these are also relatively common with almost 1 million cases per year, and 80% are related to indwelling catheters, are classified as catheter-associated UTIs or CAUTI. And the vast majority of urinary tract infections are caused by E. coli, and this just is from the proximity of rectal colonization of E. coli, and that being a prominent urologic pathogen with periurethral colonization. And that kind of leads into the pathophys. Just a quick refresher, majority of UTIs are ascending infections, so they start with periurethral colonization that ascends into the bladder and can set up shop and cause asymptomatic bacteria. There's various factors that lead to this developing into more of a cystitis versus just an asymptomatic colonization. From here, other factors that play a role in ascending further into the kidney to cause pyelonephritis and subsequent potential bacteremia if it's severe enough, or if there's obstruction or pseudo-obstruction from infiltration of white blood cells. Less commonly is the descending route, and this is where you might see more commonly Staph aureus in the urine is descending, so it started out as a bacteremia and then you found it in the urine later. And then there's also contiguous, maybe related to Foley catheterization or instrumentation or catheterization. So, diagnosis, and you can see here that there's several different categories that kind of fall under the umbrella of urinary tract infection. These include asymptomatic bacteria, cystitis, which is the infection of the bladder, pyelonephritis involving the kidney, and then catheter-associated UTI and urosepsis. And really, as you can kind of see here from the table, your urinalysis and your urine culture are likely to be positive in all scenarios. And so what really distinguishes each of these from each other is symptomology. And the UA and the urine culture aren't very great distinguishing tools to go between asymptomatic colonization versus actual infection that warrants antibiotic therapy. It's really the presence of symptoms and where those symptoms are localizing to, if it's more of a bladder versus a pyelonephritis, which usually also involves systemic features of fever, leukocytosis, and hypotension related to potentially bacteremia involvement. So, symptomology is key. And then presentation in the elderly is challenging to diagnose and differentiate from other causes of, frequently we see a lot of people elderly patients that come in with altered mental status, and I know this is classically taught as a warning sign that they might have a urinary tract infection, and I think sometimes what happens is it stops there at like altered mental status in an elderly patient, let's check a UA and culture. Up to 90% of our elderly population has asymptomatic bacteria, so UA and culture are obviously positive in that setting, and sometimes the kind of further workup stops there. We give them a course of antibiotics and fluids, and maybe they get better from that, and it could have been related to dehydration that drove the that setting, or just a transient decline related to their underlying dementia or other comorbid conditions that improved roughly at the same time. So altered mental status, what I'm trying to get at is maybe a sign that there's a urinary tract infection. It's increased in patients that were diagnosed with UTI, but it's very non-specific and can be present in many other conditions that affect the elderly population. And so, doing a workup and, if all else comes back negative and they're still continuing to have altered mental status or functional decline without a worsening of infectious signs and symptoms, and maybe this is the patient who you try antibiotics on. But work up other causes, rehydrate, look for new medications that could be contributing to change in mental status, look for other features that may have led to their current presentation before looking and nailing the coffin with UTI, because this results in unnecessary antibiotic exposure when it may not always be necessary. And then urinalysis, getting a little bit further into this and what the positive and negative predictive values are of UA. And again, the positive predictive value of all the different categories that show up in our UA are relatively not helpful. The positive predictive value of a positive UA for an actual urinary tract infection is poor, and it depends on the different populations studied, but up to 60% in otherwise ambulatory individuals versus, down to 30% or so in catheterized patients, elderly patients, where the rate of asymptomatic bacteria is much higher. However, they do have very high negative predictive value. So if your UA is completely normal, it's very unlikely that there's a presence of an infection. With the caveat that patients that can't mount good immune responses or don't have neutrophils, like neutropenic cancer patients, may not have pyuria, and so that might be something to think about in that population. But otherwise, the negative predictive value for pyuria or absence of pyuria is up to 98%. So if it's not there, there's unlikely the presence of bacteria in the urine, which then would indicate that there's unlikely an infection there. So that can be a good rule out test, but not necessarily a good rule in test. So, another question, what is the best way to distinguish between infection from colonization? I'll go back to Kahoot here. Perfect. Yeah, symptomology is really the best way to distinguish infection from colonization because, like we talked about, positive urine cultures, positive for pyuria, positive nitrite are all potentially found in asymptomatic bacteria, and so it doesn't always help us to distinguish infection from colonization. So, I think this question comes up a lot from different stewardship teams to whether or not to reflex cultures. I know we kind of went through this at our system, and it's just trying to figure out better ways to use our test or to prompt providers to use tests in a more correct manner. And this is a really good quote. How often misused tests generate misleading thoughts? And I think that goes back to clinical inertia. We see a positive result of something and we feel like there needs to be something done about it. We need to treat, such that urine culture positive for over 100,000 Enterobacter, and it looked how resistant that looked, just itching to throw antibiotics at it, and patient was otherwise doing fine. We'd probably do more harm than good treating them with broad spectrum antibiotics in that setting. And so there's a lot of inertia from positive results. So many people have kind of looked at, well, can we reflex to urine culture based on a positive UA, and will that have an impact? So if the UA is negative, we don't do a culture on that patient. Thus, if there's no culture, there's no inertia to treat something that we didn't even know was there to begin with. So I think this is, kind of very good logic to think about, but there's also some other considerations that should be included in that that may get missed in the initial piece of this, and we're just kind of thinking about like not using a test. And so what this kind of comes down to is that urinalysis and UAs have been frequently misordered or ordered inappropriately. A recent study found that 68% of reasons for culturing were either inappropriate or not reported and had no clear indication on retrospective chart review. So there's sometimes not a great reason why UA is ordered, and then the reflex to a positive UA is like, oh, maybe I need to get a urine culture, although it's like, well, the patient doesn't have any symptoms, so why am I doing this again? So kind of thinking about that, but it's interesting, that's a pretty high incidence that these tests are being ordered inappropriately. This next study by Epstein looked at using reflex cultures in the ICU, and they found that it led to a significant decrease in the number of urine cultures and decrease in the number of CODIs diagnosed. The authors in this paper actually didn't comment on the antibiotic use data, which would have been more interesting to see if there was a decrease in antibiotic use, as you would expect there to be if there was less cultures being done and less culture positives being done. However, I would say that the presence of pyuria and the reflex to culture and the positive of culture still doesn't get at the fact that if the patient doesn't have symptoms, they probably don't have a UTI. It's kind of substituting one for another. And that's what this next group looked at is this was a predominantly ambulatory elderly population that they found, as we've talked about, elderly have a very high rate of asymptomatic bacteria, up to 90% in some studies. And so you'd expect that with asymptomatic bacteria, there's going to be a high rate of pyuria and leukocyte esterase as well, because bacteria in a normally sterile setting, your body's going to respond somewhat to that. And Dietz looked at this, and they actually removed reflex cultures because they felt like it was leading to a lot of unnecessary treatment of ASB, and they saw a significant decline in the number of cultures being performed and a non-significant trend towards reduced antibiotic prescribing. So I think it's an interesting, here or there. So I think you really have to consider your patient population and where maybe the problem exists. Reflex may work well in some places. Reflex may actually have the opposite effect of what you're trying to do. So you kind of have to weigh that, and I think it kind of goes all the way back to the very upstream point is, should we be ordering the UA in the first place? Should we be ordering the urine culture in the first place if the patient is asymptomatic? And using, the presence of symptoms to guide us to test appropriately after that. And these are just some examples from our handbook that we publish and produce and send out to providers, pharmacists, APPs, and kind of our UTI algorithm, and really focusing on, if they don't have symptoms, don't test. I think is really the big message there. If something else is concerning, you could consider testing that patient, and then if the UA is negative, it's a very strong predictor that there's not an infection, but a positive UA still doesn't always indicate that there's an infection versus just colonization. So you have to use a lot of your clinical judgment to kind of discern that and, judiciously use antibiotics in that setting if there's feeling that there still is an infection that would benefit. And I say all this, we'll talk about asymptomatic bacteria. There's two populations that we do screen and treat asymptomatic bacteria for, but I'll get to that in a second. So again, some key points here. We've really addressed most of this, but UA is a poor test to rule in UTI presence. A negative UA has a very high negative predictive value that bacteria aren't present in the urine, and so would be a good test potentially to avoid getting a culture in that setting. But you still need to use clinical discretion. I think it's better to look at how to improve initial ordering of UAs by providers in patients that truly have symptoms that need to be worked up. And not all symptomatic patients, as we'll talk about here in a second, even need a urine culture. You can potentially just go straight to treatment because the presence of symptoms are very good at predicting the likelihood of UTI. This slide just really goes through all the different patient populations that have been evaluated and the incidence of asymptomatic bacteria. And you can see here it ranges from 17% in hospitalized patients without catheters to 30% with catheters, and then up to 75% in nursing home residents. And this can even go up to 90%, as we talked about from some other studies in elderly patients. And this is the data why we don't need to treat asymptomatic bacteria. Many studies have been done trying to show that antibiotics may have some benefit in treating asymptomatic bacteria. However, they consistently fail to show a benefit and likely just exposing patients to more side effects, risk of colonization with resistant pathogens in the future, and other effects like C. diff and excess cost. The two populations that I mentioned that we do see benefit in screening and treatment is pregnant women. That's usually around 32 weeks when we screen and potentially treat them for asymptomatic colonization. And then patients undergoing invasive urologic procedures, especially those that there's going to be some mucosal bleeding to prevent infection and sepsis. So, moving on to treatment. Just included this slide for your reference. These are some resources, guidelines that are published out there for use that are good, although some of them are a little bit older. Hopefully we're coming out with some new ones soon. Starting off, we'll start talking about antibiotic selection for cystitis, uncomplicated cystitis. And you can see here by the organism breakdown that the vast majority of these are caused by E. coli, 81%, followed by Staph saprophyticus, Proteus, Kleb, and a few Enterococcus. So really targeting E. coli is probably going to be the biggest bang for your buck in most of these instances, and where the guidelines kind of went with their empiric recommendations for treatment. There's usually low rates of antibiotic resistance for the most part. However, Bactrim and quinolones, as we've seen community-wide and nationally, rates of resistance have increased, likely related to overuse of them for various infections. So with the IDSA recommendations, came out and said nitrofurantoin, fosfomycin were kind of the top two. I left off pivmenicillin because we don't have that. But Bactrim only if the rates of resistance are less than 20%. And then alternatives include beta-lactams and fluoroquinolones. However, increasing resistance and side effects, these should be kind of reserved as, third, fourth line agent. So another case scenario. Which of the following choices is not an appropriate empiric antibiotic selection for uncomplicated cystitis in an otherwise healthy young female patient? All right. Cipro would not have been an appropriate selection in that patient. Macrobid or fosfomycin, potentially Bactrim, depending on your local resistance rates, would have all been considered reasonable, favoring macrobid first line for uncomplicated cystitis. Okay. It went back a bit, sorry. All right, so fluoroquinolone use. So I think everybody's probably tired of hitting fluoroquinolones, but they're easy targets. They're good agents when we need them, but really should be reserved for more complicated infections or patients with multiple allergies where, because they do have a lot of collateral damage, they have a lot of side effects, and are associated with a higher incidence of C. diff infections. And the FDA keeps releasing more and more warnings about quinolones, just probably trying to hopefully urge people to not use them in most cases of uncomplicated infection, reserving them for more infections. But some of the more recent ones were the early 2016 safety warning that just warned about serious effects and should weigh risk-benefit and really reserve them for more complicated infections. And then subsequently, later in 2016, talking about what was that? Tendinopathy, tendinopathy, muscle joint, nerve disorders, and then the other one is dysglycemias. These are pretty rare complications of fluoroquinolone, so don't want to scare anybody away if it's an appropriate choice, but I think the FDA is just trying to make sure that people are aware of the potential debilitating side effects from inappropriate fluoroquinolone use, and that these are usually reserved for more complicated infections or more complicated history where there might be resistance or might be other considerations in terms of allergies, cost, and things like that. So this slide just really summarizes some of the available studies for cystitis, and you can kind of see the running theme there in the highlighted or bolded portion is that shorter duration is usually better. Or non-different than the longer duration. You save on side effects and costs from shortening the duration and doesn't appear to impact the outcome overall. So for uncomplicated cystitis, 3 days for most things, 5 days if you're using macrobid, or even a single dose for fosfomycin is appropriate. However, there was a recent study that was just published in JAMA earlier this year that compared macrobid to fosfomycin. And interestingly, this was a multinational open-label randomized trial of non-pregnant women over 18 years with uncomplicated cystitis. They were given 100 milligrams 3 times a day, which is different from BID, of macrobid versus fosfomycin 3 grams as a single dose. They looked at clinical response at 28 days and actually found macrobid was better than fosfomycin in the study. And what is peculiar about this study is that the overall rate of clinical success or clinical response at 28 days is much lower than earlier studies. And so it's hard to put this together. I haven't quite put my finger on what exactly was maybe going on with this population. I would say that there was a very low frequency of E. coli. Only about 60% of E. coli were cultured in the study, which is different than the 80+% incidence that we usually see from E. coli. Some thoughts is maybe fosfomycin as a single dose, maybe it needs to be a repeated dose. It's not quite clear. I think there's some questions that need to be addressed from this study, but just kind of looking overall, that macrobid may be a slightly better option than fosfomycin. The other thing to think about is fosfomycin still brand and still pretty expensive, so we tend to favor macrobid over fosfomycin anyway because of that. We haven't seen too much in the way of failure with fosfomycin in this, so it's hard to totally put it down, but I think it's an interesting study conclusion and finding. When they did look at progression, when they looked at progression to pyelo, there wasn't a significant difference between macrobid and fosfomycin, and then also when they looked at duration of symptoms, it was actually a day shorter with fosfomycin than macrobid, so those were interesting with the association of just decreased response from fosfomycin. So with all of that, what do you pick? How do you pick it? There's a lot of, I think, considerations that go into picking empiric antibiotics and kind of constructing guidelines for uncomplicated cystitis. Patient factors should be considered, the patient population that you're serving, allergies, kidney function, age, prior infections, things like that. What do the guidelines say in terms of efficacy differences between different therapies? Local epidemiology and resistance, and that's where I throw up the antibiograms here. There's a lot of data on these. The top one is actually the Colorado statewide antibiogram that was put together with the help of the CDPHE, Dr. Seja, and all the hospitals and facilities around Colorado that submitted their antibiograms. So, you kind of look here and see that overall for E. coli, which there was a lot of, over 40,000 isolates, you see that Bactrim and quinolone's not that good. Cefazolin, macrobid, although macrobid not listed, are reasonable options. And then when you look, I put ours up here from our outpatient urine-only antibiogram, and kind of goes into why we chose what we chose for ours, and that macrobid's over, I think it's 98%, 98% susceptible for E. coli. It's cheap, it's effective, and so that's our first line recommendation. Bactrim, we still see in the community a greater than 20% resistance, and then with quinolones, we see about 18%. This is definitely improved from years past where we had well over 20% resistance in our E. coli, and I think a lot of that's due to just global stewardship interventions and cutting down on fluoroquinolone use. And then cephalexin was 91% susceptible, so that's actually our second option before fosfomycin, just thinking about costs associated. So we use Keflex as our second line recommendation for people who can't do macrobid. It's cheap, it's effective, and looking at our antibiogram, we have a high rate of susceptibility. This is using different breakpoints, so that's one thing to keep in mind. For cefazolin, which most people run for susceptibility, the CLSI, which governs the susceptibility breakpoints, lists two different breakpoints for cefazolin, one for systemic infections and one for urine only. The one for systemic infections is a cutoff of 2. The one for urine only is a cutoff of 16. And so using the cutoff of 16, you can also predict to other oral cephalosporins like cephalexin, but it's only for urine only isolate and for uncomplicated cystitis. So that might be something to look at with your lab and kind of what breakpoint are you using for urine, and to better characterize maybe what the true rate of resistance to Keflex is in that group. In terms of pyelonephritis, uncomplicated pyelo, the types of organisms that we see are generally similar to uncomplicated cystitis, predominantly E. coli, a little bit higher Klebsiella than in uncomplicated cystitis, but predominantly enteric gram-negative rods. IDSA recommendations are either IV or PO fluoroquinolone, not requiring hospitalization and local resistance less than 10%. If local resistance is greater than 10%, they say give IV quinolone first, or a different agent that's a long-acting, such as ceftriaxone or aminoglycoside. And then oral antibiotic therapies include fluoroquinolones, cephalosporins, and Bactrim if susceptible. So actually a few questions with this one, but they're pretty short, so hopefully we can knock them out real quick. Okay. In those with significant complications, what is the recommended antibiotic duration for pyelonephritis? 5 to 7 days, 10 days, or 14 days? All right. Most everybody got it right. 5 to 7 days is what's recommended in most cases for pyelonephritis. Should a patient with uncomplicated bacteremia secondary to pyelo receive longer antibiotic durations? Yes or no? Good deal. So, correct. Mostly standard duration of therapy for bacteremic pyelo is adequate. For those with pyelo initially managed with IV antibiotics, could you transition to a non-fluoroquinolone PO therapy, such as a beta-lactam or Bactrim? Yes or no? Yes, good. Yeah, it's appropriate to consider beta-lactams or other non-fluoroquinolone step-down options. There appears to be no difference in efficacy, as we'll talk about. So y'all have already got this. I can just stop now. All right. So this is a cool. Does that work? Okay. This is a nice summary table that just kind of highlights some of the studies that looked at different treatment options for pyelonephritis, as well as different durations of therapy. And as you can see here, particularly most of the data from short duration had been with fluoroquinolones, and they didn't show a significant difference between 5 to 7 days versus longer durations compared to a different quinolone or Bactrim. And then we have the ceftriaxone daily versus ceftriaxone transition to ceftadorin. And again, they really didn't find a difference, although their duration was 10 days, a little bit longer. But what we're finding from other studies is that 10 days is still probably a little bit longer than needed in most scenarios, especially if patients respond quickly and improve within 48 to 72 hours of effective antibiotic therapy. Presence of bacteremia and its impact on duration of therapy. Well, from urine sources, pyelonephritis, we really don't see that there's any impact in terms of clinical outcome differences between shorter versus longer duration of therapy. This was a meta-analysis. It's a bit dated now, 2013, but still the trend there was really no difference when they put everything together. And they didn't see a ton of heterogeneity based on the I-squared value down there in the left. This next study was a really nice study that came out from Tama's group, and they did a nice retrospective propensity-matched cohort analysis comparing short versus long duration. It was 6 to 10 days versus 11 to 16 days was included as the short versus long, respectively. This was multi-center. They looked at initial episode monomicrobial bacteremia with an Enterobacteriaceae organism, such as E. coli or Klebsiella. They excluded durations outside of this, and then high-risk patients such as stem cell transplant, solid organ transplant, and hospice patients. And baseline characteristics are relatively well matched. Most of the sources of bacteremia were from urine. I think over 60% were urine, followed by GI, biliary, and catheter-related bacteremias. When they compared the results short versus long, they found no difference in 30-day mortality, 9.6% in short versus 10.1% in long. And then secondary recurrence was also not different. CDI, interesting, which C. diff infection is also interestingly not different. Would have thought there might have been a trend towards more in the long arm. And then MDROs was a trend towards more recovery of MDROs with longer duration of therapy compared to shorter duration. What about oral step down? As we talked about, Mercuro in a relatively recent publication in International Journal of Antimicrobial Agents looked at quinolones versus beta-lactams as PO step down therapy in patients with bacteremia from Enterobacteriaceae, and they found after stabilization and or source control, they didn't find a difference between whether the patient was stepped down to a PO beta-lactam versus a fluoroquinolone, and they also did subgroup to look at whether or not the duration of therapy impacted their outcomes with quinolone versus beta-lactam, and again, they didn't find a difference in short duration beta-lactam versus short duration fluoroquinolone. So beta-lactams are reasonable to consider for oral step-down with clinical improvement and culture or pathogen identification and susceptibility results. Predominant of beta-lactams used in this were augmentin, followed by amoxicillin, actually Keflex, and ceftonir. So some take-home points about pyelonephritis. Empiric antibiotic selection is guided by kind of patient characteristics, severity of illness, your local epidemiology, any previous infection history, kind of management location, whether they're going home or staying in the hospital. Empiric quinolones are generally recommended to be avoided if their local resistance is above 10%. If you're going to use that, then preference to use a consolidated dose of a long-acting agent, either an IV quinolone, IV aminoglycoside, or IV ceftriaxone. A lot of the reasons we're probably using fluoroquinolones is they're beta-lactam allergic, so kind of excludes that one. I honestly think aminoglycosides in most instances are probably underutilized for urinary tract infections. They have very great efficacy in that setting, and a one-time dose is very unlikely to result in any side effects such as nephrotoxicity or ototoxicity. Even up to 3 doses, probably very unlikely to have any adverse effects. So in UTIs, aminoglycosides are wonderful drugs and retain a very high rate of susceptibility, probably because of lack of routine use. So these are still reasonably good options. And then in most cases, the duration of therapy doesn't need to exceed 7 days. There's always exceeding circumstances where you might need to treat somebody a little bit longer with delayed response, immune compromising condition, anatomic defects, or presence of stones, tubes, things that make them more complicated. In terms of complicated UTI, and people can be complicated because of structural functional abnormalities. They can be complicated because of immune suppression, presence of foreign body, things of that nature. For the most part, the thing to think about for these patients are higher risk of having more multi-drug resistant pathogens, and they may not respond as well as a normal host would. So also the breakdown in epidemiology, you still see E. coli as a predominant pathogen here, but now it's down to right around 60% from 80%, so a much less frequency that we see E. coli, and then we start to see more gram-positive pathogens such as Enterococcus faecalis, a few Staph aureus, and then we see more of our resistant gram-negative start to pop up, such as Enterobacter increases in likelihood, Citrobacter, Pseudomonas. So these patients, again, may warrant additional considerations for the likelihood of having a resistant gram-negative pathogen as well as gram-positive, so kind of take those into account. These were a couple of nice papers that looked at the prevalence of antibiotic resistance and some risk factors in elderly patients with UTIs coming in, and what they found was the first study looked at about 400 patients with complicated UTI, and 37% had a multi-drug resistant pathogen. Significant risk factors that predicted acquisition of multi-drug resistant pathogen was age 65 and over, urine catheterization, and antibiotic use, previous antibiotic use. And then in another study looking at E. coli in nursing homes, they found a very high incidence of quinolone and bacterium-resistant E. coli. So take-home points about complicated UTI. Empiric antibiotics should kind of be guided on the basis of the complicating factor for the patient, other patient characteristics, previous infection history, as well as previous culture data to kind of guide, if they're colonized with an ESBL, then you might want to start with something that has some of that coverage. If they have a Pseudomonas frequently in the past, then you might want to empirically cover Pseudomonas in that patient. If they have a lot of Enterococcus that's been recovered, or they have lots of instrumentation, Foley catheterization, then you might cover some more of the gram-positive end. And so just some different considerations there in terms of what to pick up front. Short course duration may not be appropriate in some of these patients. It really depends on their response to therapy and what exactly their complicating feature is. So it just takes a little bit extra consideration and thinking about their likelihood of having a resistant bug. In terms of CODI management, I think key to CODI management is removing the Foley catheter, or at least replacing it. In studies, they found that there was shorter time to clinical improvement, resolution of fever, and response to therapy if the catheter was removed or exchanged than if it was left in place while you tried to treat it. Treatment studies have shown various things in very uncomplicated, straightforward, minimal symptoms, catheters completely removed. They actually found a single dose of Bactrim in this population was as effective as 10 days of Bactrim. In mild CODI, 3 days was just as good as 10 or 14 days. And then complicated with Pylo, or CODI with Pylo, 5 to 7 days is usually a reasonable if they have consideration if they respond to treatment quickly. And this is just a summary of the IDSA guideline recommendations for the different CODI infections and patient characteristics and response to therapy considerations for duration of therapy. I'm not going to get into really treatment options for MDROs, but here are some just recently approved things. Novel beta-lactamase inhibitor combinations have all been approved for complicated UTIs. These are options usually reserved for more resistant infections or carbapenem-resistant organisms. And then plasmamycin is a new aminoglycoside that has very high activity against very resistant Enterobacteriaceae. Older therapies such as broad-spectrum beta-lactams, such like carbapenems, cefepime, ceftaz, and piptazo, or combinations are reasonable. And then there is some data with complicated cystitis using fosfomycin with an extended duration, so 3 grams every other day for 3 doses, had a relatively good success rate in this population and has activity against VRE and ESBL E. coli. So maybe a consideration for somebody to avoid IV therapy if they have a complicated cystitis with a resistant pathogen. And this one I just wanted to highlight. This is the impact of team effort on UTI durations. So this was we made this a pharmacy goal for our pharmacists at UCH, and we did a lot of education from the stewardship team to providers and our pharmacy group, and everybody just kind of pulled together to really target. We found our UTI durations were on average about 10 days, and our goal was to get that down actually to just 9 days. We wanted to see a 10% reduction given that the heterogeneous population and a lot of sick people, so we're being a little bit more conservative, and actually through a lot of education, through a lot of just identification and targeting by our pharmacists and our physician groups, we were able to get our UTI duration down to 7 days on average. So it takes a village, but it can be done. Moving on, preventative strategies. So just a little bit of brief information about CODI. It's a relatively common infection in the hospital. It's one of the most common causes of healthcare-associated infections. However, it's also one of the most more preventable infections. So about up to 70% of CODI is preventable, and through prevention, there's significant savings that have been estimated. And how you can do that is kind of managing your modifiable risk factors that are listed here. So duration of catheterization, adherence to aseptic insertion techniques and hygiene, using protocols to remove patient's catheter when it's no longer needed, and not even placing it to begin with if it's not needed. And so different things that you can affect, and that's really kind of best divided into 3 different strategies here. So placement, so avoid unnecessary placement if possible. Studies have estimated that 20 to 50% of catheterization may not be necessary. So avoiding initial insertion to begin with prevents infection. Institutional protocols for placement, using alternatives if those are reasonable alternatives, such as condom catheterization or intermittent catheterization, have lower incidence of CAUTI than long-term indwelling Foley catheterization. Care, so using aseptic sterile technique with insertion and good hand hygiene when taking care of the catheter. Closed system and gravity, so making sure that it's beside the bed or below the patient, so that there's natural gravity flow and you don't get reflux back into the patient. And then multidisciplinary and evidence-based practices for just global care. And then removal systems in place to remove catheters early, daily assessment reminders, and nurse-directed removal. So this was just some education that took place. This was published in Journal of Emergency Nursing. This was actually done over at UCH with a group of the ED and some other quality improvement folks there, and they found that through education, they were able to decrease the number of catheterizations that took place in the emergency department. And then these 2 studies looked at the difference between nursing-directed interventions as well as informatics-led interventions, and both of these are highly effective in reducing the duration of catheterization, so prompting that it's no longer needed, either by a bedside nurse as part of daily rounds or through a CPOE-generated alert to the clinician that, hey, reassess the need for catheterization. It's been in for a day or 2. Those types of things. So, another question. What is the most effective strategy to reduce the frequency of recurrent UTIs? We haven't gotten to this yet, so I'm interested what people are going to say here. So your options are increased water intake, continuous low-dose antibiotic prophylaxis, cranberry products, or probiotics. Okay, awesome. Everybody must have read the recent paper. Very good. So increased water intake is one of the most effective strategies in preventing recurrent UTIs. There we go. So, briefly, just to run through, this was a recent study published looking at continuous antibiotic prophylaxis, and this was a randomized open-label superiority study that looked at daily low-dose prophylaxis for 12 months versus no prophylaxis in patients with a history of recurrent UTIs. They did find they used macrobid, trimethoprim, or cephalexin. Vast majority of patients, 99%, had catheterization required, and 2/3 of patients had at least 4 previous episodes in looking at their baseline characteristics. The frequency of symptomatic UTI fell from 2.6 to 1.3, which was statistically significant. However, there's no difference in the incidence of febrile UTIs, 0.11 versus 0.16. Side effects were definitely more common in patients receiving antibiotic prophylaxis, 9% versus 2%, and recovery of resistant pathogens to the prophylactic agent was definitely more common versus control, as you would expect. So more side effects, more resistance for maybe 1 fewer UTI episode. So they're options, but should generally be reserved as kind of like all else fails. The continuous antibiotic prophylaxis has a lot of negative effects associated, so we should really try and reserve this for very refractory patients. There's other things continuous to consider. You could do like episodic base, so when patients have onset of symptoms, start taking something for 3 to 5 days, or if it's finding out what the risk factor is most associated. So if most of the time they're getting UTIs after intercourse, then maybe considering postcoital prophylaxis after they have intercourse, and counseling some behavioral modifications, hygiene modifications around that, to consider urination before and after intercourse, and avoidance of spermicidal agents that have shown to increase the risk of UTIs in that setting. So some alternatives: continuous antibiotic prophylaxis may work, but at what cost? And then the other one is the effect of increased water. So this was a JAMA Internal Medicine paper from October, and they randomized women in an open label fashion for 12 months to either have increased fluid intake of at least 6 glasses per day in addition to what they normally consumed, or no intervention. And they looked at all women had to have at least 3 previous episodes of cystitis in the last year. And then their primary outcome was frequency of recurrence in the 12-month period after the randomization. So they looked at the mean urine volumes were significantly higher, as you would expect. You drink more water, it's got to come out somewhere. So increased volume, increased number of weights per day. So in the increased water intake arm, there was about an average of 8 urinations per day versus about 6 in the control group, so about an extra 2 urinations per day. However, the number of recurrent episodes was significantly lower, 1.7 versus 3.2, which is increasing your daily consumption of water by 6 glasses. Which is actually quite a bit when you think about it. I tried it, and it takes some dedication to get that much extra water in. And then the mean number of antibiotic courses actually was significantly lower as expected, fewer episodes of cystitis, less antibiotics. So a cheap way to prevent UTIs. You probably will hear about the patient having to get up over the night, though, because of all the extra fluid they've taken in. But no more UTIs. And then this is just kind of a summary of various preventative measures. There was a nice review article in Nature Reviews in Urology, running through the different things. I think here most effective fluid, some behavioral strategies like we talked about, avoiding spermicides, post-void or post-intercourse voiding may be effective. Fluid intake definitely effective based on that recent publication. Cranberry, mixed evidence, some positive, some not different versus placebo. It seems like most studies are found to be beneficial in women with recurrent UTIs. It has a relatively low risk profile. Just use caution if they're using the juice and had a history of diabetes. There's probably a lot of extra sugar from that. So maybe the capsules, if that's a consideration. But again, not enough clear evidence to make a clear recommendation towards that. But some benefit has been shown. NSAIDs, not much evidence for prevention, although there were some studies looking at NSAIDs for treatment of cystitis, and actually found in some studies they found NSAIDs was not different than antibiotics for treatment of cystitis. Patients that have longer duration of symptoms, and quite a few more of them progressed to pyelonephritis than those that received antibiotics, so probably not the best thing to consider for treatment of uncomplicated cystitis, but it's out there. Antibiotics we talked about, probiotics, mixed and very heterogeneous data to talk about this, oral versus vaginal insertion of probiotics. It appears that the Lactobacillus rhamnosus GR1 and Lactobacillus reuteri RC14 have some consistent literature showing that they maybe reduce UTI frequency. Methamphetamine definitely reduces. It's a product that gets transformed in the urine to formaldehyde and has bacteriostatic effects, and so maybe a consideration non-antibiotic to reduce recurrent UTIs in certain populations. Just be cautious of their renal function. Estrogen in postmenopausal women, topical, has shown to effectively reduce UTI recurrence. And D-mannose is something that's looked pretty promising, although there's not enough evidence to make any recommendation, but the mechanism's pretty cool. So, conclusions and opportunities for stewardship. Optimize diagnosis and prevent treatment of asymptomatic bacteria. Use judicious ordering of urine testing there. Increase fluid intake as a good strategy to prevent recurrent UTIs, and limit daily prophylaxis when possible with antibiotics. Tailor antibiotic selection, so utilize local resistance patterns, your antibiogram, formulary status to devise guidelines for approaches to managing uncomplicated and complicated UTIs. Avoid fluoroquinolones when possible. There's always those circumstances where it's the best drug, and when you use it, just make sure you use it for the correct duration of therapy, as with anything. Narrow options when available, and you have susceptibilities back to something narrower spectrum, and then use appropriate durations. So with that, I'd like to invite any questions. And thank you all for listening.
Yeah, one from the video conference. Microbit is considered a high-risk medication for individuals over the age of 65. Do you still recommend Microbit as a first line in this age group as well as for uncomplicated cystitis?
So just to make sure I heard the question correctly, it was, is Macrobid appropriate for age over 65 as first line for uncomplicated cystitis? Okay. This is an interesting question. There's been a lot of debate about macrobid use. The current package insert recommends avoiding it in creatinine clearance below 60. However, that is based off of no evidence that I'm aware of. The old package insert allowed you to use macrobid down to creatinine clearance of 30, and with shorter durations, there's unlikely systemic side effects. It's more about whether or not it's going to be effective and reach high enough urine concentrations if they're not getting adequate urine elimination. But from 5 days, I think the risk of side effects is relatively low, and we continue to recommend it for those who are over 65 as long as their creatinine clearance is above 30 to 40. Thank you.
All right, you guys, couple things, and then we will break to go to the concurrent sessions. The first thing is I want to introduce my colleague and friend who just had a baby, so that's why she didn't get here till late. This is Jyoti Mahatra. She is from the School of Pharmacy, and she is the continuing education person over there, like I'm for the College of Nursing. And Jyoti gets to be my Vanna White and choose from this. I'm going to spread these out so we can decide, find out who gets to have the free registration. I should record a drum roll or something exciting like that. All right, so they're kind of spread out. All right, Jyoti.
This one.
All right.
That's the winner.
Okay, and the winner is Chris Hatrick, Christine, or is it? It looks like it's Hartrick. All right. I must have said it somewhat right. So if you want to find me afterwards, I'll keep your card for sure. So congratulations. All right, the next thing we will do is divide up into the two different concurrent sessions. Let me just tell you where everybody's going to be, or where the different talks are going to be. In this room, the next one will be the management of acute respiratory infections, followed by the duration of treatment for common infections. Up on the second floor is post-travel treatment for common infections, and then infectious disease self-care, evidence for OTC medications. So if you want to go to the post-travel, just go up the stairs to the second floor, and someone will, I believe it's down this direction, down that second floor hallway. There's also fruit and stuff out front if you guys want to help yourselves. And we'll start the next sessions in like 5 minutes, so walk fast. Thanks, Jyoti.
Yeah.
All right, we're going to go ahead and get started. So if anyone has more questions for Dr. Miller, I'm going to ask you guys to kind of step out a little bit, and we'll try not to be too late here. So it is my great pleasure to introduce one of my very favorite ID people, and this is Dr. Ann Christine Nyquist. Actually, she goes by Chris Nyquist. She is a professor of pediatrics in the section of infectious disease and epidemiology at the University of Colorado School of Medicine and Colorado School of Public Health. Her infectious disease clinical practice is based at Children's Hospital Colorado, where she serves as the medical director of the Infection Prevention and Control and Occupational Health. She is a graduate of the University of Michigan School of Medicine. I should have paid attention. And completed her pediatric residency at UCLA and her pediatric infectious diseases fellowship and Masters of Science in Public Health at the University of Colorado. She is a fellow of the American Academy of Pediatrics and the Pediatric Infectious Diseases Society and is a member of the Society of Healthcare Epidemiology of America and the Infectious Disease Society of America. She serves on national leadership roles as the chair of SHEA's Pediatric Leadership Council and the American Academy of Pediatrics Committee on Infectious Diseases. Her clinical and research interests, I don't know when she fits those two things in, include healthcare epidemiology and infection control, healthcare disparities, and pediatric infectious diseases. Please welcome Dr. Nyquist.
All right, gang. So just for a kind of a weather check, it is kind of nice outside. And so I will work on keeping your attention with a really broad conversation talking about management of acute respiratory infections in ambulatory care. And so I know we have some people on Zoom, and so for questions, we'll use the microphones. But let me get going. So these are my financial disclosures. I've been on an advisory board for influenza vaccines for one of the vaccine companies and also on a data safety monitoring board for a neonatal antibiotic study serving as the chair. So what do we want to do? So I'd like to describe the epidemiology of acute respiratory infections in the ambulatory setting. And this is really from time 0 of life to year 100. And one of the things that you know as you deal with children and adults and everyone in between is that there's many similarities from the beginning of life and the end of life. And so we'll really go for the gamut. I want to talk specifically about some of the viral kind of issues that we need to deal with currently as we're looking forward to our RSV bronchiolitis season and influenza. And then some of the management things with talking about, the drugs that we need to use for strep pharyngitis, community-acquired pneumonia, and pertussis, which is one of my favorite things. So when I think about everything for infectious disease, I always think about how do I think about what someone's going to get? And so I usually think about the epidemiologic triangle. And so starting with the host on the top, which is really based on what's your age, what's your immune status, what are the organisms, and then what is the environment? And all of those interact in order to give you a risk for infectious disease. Some of the organisms have specific virulence factors that are important. The host and the environment interact with modes of transmission, and then the environment can get you sick because you can have contaminated surfaces and have lack of sanitation, sterilization. So it ultimately comes down to this. The bug, no one is immune, it's infectious. So I always have a good day job. So acute respiratory infections. So let's talk about the hosts. And so the different age ranges. And so from neonate to adults to elders and immune status, the comorbidities are important. I want to focus on a virus versus a bacteria because there's things that we can do for viral infections. Very few antiviral treatments, but there's a lot of different antibiotics that we can use, and we need to use them wisely. But my real mode in life is really how do you prevent these infections, and thinking about infection prevention and control in terms of vaccination is one mode. We can use medication, but the common sense things of, mama told you to wash your hands, cover your mouth when you cough, that really is the cornerstone of what we're talking about with acute respiratory infections. Now, one of the things that we know is that we have a seasonality to things, and right now we are in November, and so we are starting to see, let's get the laser pointer here, we're seeing some kids with a few kids with croup, a little bit, not very much. We've only had a couple of cases of influenza. Influenza season is coming. Only a couple of cases of RSV. We've had enterovirus over the summertime, and many of you have read about the acute flaccid myelitis, the AFM, which has been associated in our studies with enterovirus infections that we've seen, and that's one of the things that we're really discussing nationally right now. All throughout the year, rotavirus still is a player, parainfluenza 3, and then human metapneumovirus. So one of the things I'd like to promote is actually the idea of one of the things that we provide at Children's Hospital Colorado, which is great for any office practice to have. And here's the email for you, emailing our administrative assistant, Carolyn Brock, or you can email me and I can get you connected so you can be on the list. So on a weekly basis, what we do is any kind of laboratory tests that come into our laboratory, Children's Hospital Colorado, from around this area, we put onto a graph and we show, here is the rate of enterovirus coming up through the year. These are GI viruses on the bottom. And you can just see what we're seeing in the community. And one of the things that this really helps is that conversation with families and patients to say, these are the viruses that are circulating. You don't need antibiotics for your cold. This is what we're seeing. Here's what's going through the community. We've actually expanded this, and we have an internal one that's accessible through our intranet at Children's Hospital, really for people to actually dig into the data to find out what's circulating. We call it Bug Watch 2.0. A little challenging to see, but one of the things that we also report on is what are the different tests that we have available for the respiratory season. And when you think about your own setting, you need to know what you can get quickly and what you need to send out. And so influenza A and B, some places will do a rapid test. We actually do a rapid PCR test, which will distinguish influenza A and B. We're actually able to subtype the influenzas. RSV and all of these other virus we do in a PCR test. So one of the things to think about with RSV is, so if you have a rapid detection, so a direct fluorescent antibody or other rapid test, it's not a good time to start doing that test because the prevalence of illness is not very high. And so you're going to have a lot of inaccurate results. And so you may have a false positive and because there's not enough circulating around. We also are able to do pertussis PCRs, which we can actually get Bordetella parapertussis, chlamydia pneumonia, and mycoplasma, and the turnaround times are really pretty quick, but the costs are actually pretty high. And if you've ever paid out of pocket for a respiratory virus panel, you know that the out-of-pocket cost can be almost $1,000 for what the charge is. So you have to really use these in a smart way. Now, I alluded to that we have lots of viral infections, and we know that for viral infections in the real world, people will want to get antibiotics, even though it's a virus and it's not going to make a difference. This is from the Pew Charitable Trusts, and this looks at outpatient antibiotic prescriptions by diagnosis. And so you take a look at this is the entire universe of all antibiotic prescriptions, and you'll see that almost half of them are related to acute respiratory conditions. When you divvy those up, the top one is sinus infections, followed by ear infections, pharyngitis, but then we still have this cluster of viral upper respiratory infections, still 12%, and bronchitis, bronchiolitis, 12%. So still about a quarter of antibiotic prescriptions in the U.S. are given for viral infections, if you take a look at URIs and bronchitis, bronchiolitis. Pneumonia, non-viral, smaller number, and then some people do it for asthma and allergy. Let's move it forward a little slow on the. I'm trying to move it forward. And it's just in a loop. Maybe I'm impatient. That probably is true. So show of hands while we're getting technology to go. Who has been felt pressured by a patient or family to give antibiotics for a cold? Okay, pretty good. Who has not? Okay, so at the end of this, you're going to have to give what your special juice is for kind of why you have, not kind of had the issue with people giving you perfect. That's
Okay,
yeah,
now you're
great. Kind of the pressure, but it is a well-known pressure that people will do, and a lot of people have spent their entire career studying this. So when we take a look at outpatient antibiotic prescriptions, who are the biggest players to get this? And so it's really the 0 to 2-year-old folks who are the most likely ones to get antibiotic prescriptions at 1287 per thousand. So that means that more people get antibiotics than actually exist in that population. 3 to 9 years of age is the next one. And then you take a look at greater than 65 is the next biggest player. So you can look at both ends of the spectrum for antibiotic use. Now, we live in the square state of Colorado, and so the darker blue, and so these are not political maps, remember, so there's no color distinctions. This is really outpatient antibiotic prescriptions per 1,000 people by region. And so you can see in the south and the southeast of the United States, that's the highest rate of antibiotic prescriptions by region. The west, and inclusive of Colorado, is actually the lowest, and then pretty high is also New England. So let's think about what's coming up with influenza season, because people are going to be coming in sick with influenza. So we know that influenza is a viral infection, so what are we doing with that? So this is specifically for pediatrics, and this was just published in JAMA Network Open in 2018 by Havers and has gotten a fair amount of press. And so looking at the pediatric population here, so you have antibiotics almost indicated, that would be pneumonia, potentially indicated with the sinusitis, otitis, pharyngitis, and then this whole tier 3 where antibiotics are not indicated. So the dark blue color is where people have had influenza that's been confirmed by the laboratory. So you can see that for antibiotics not indicated, people had bronchitis and they were given antibiotics and actually had influenza. And actually pneumonia and pharyngitis, the other ones, were very small amounts of cases that had influenza. So that's the peds world. What about the adult world? So antibiotics almost always indicated with pneumonia, and then the same ones, pharyngitis, sinusitis, otitis media, and then the other ones where it's not indicated, you have kind of the URIs and bronchitis and other things. So influenza season, a lot of people are actually coming in with pneumonia, but also have influenza. So thinking about those dual infections is important. We know that acute respiratory infections in this study were defined as cough with 7 days duration or less. They had pediatrics defined as 6 months to 18 years. And the antibiotics that they chose found out for this study were really interesting. The narrow spectrum antibiotics, the pediatric group actually got a fair amount of the narrow spectrum penicillins. And what we saw in the adult populations with the dark blue, a lot of them got macrolides. So azithromycin, clarithromycin as the macrolides were the most common antibiotics that were given. So we know viral infections get a lot of antibiotics. So how are we getting these infections? So when we think about the transmission of respiratory pathogens, sometimes when you cough and sneeze, you got big droplets, and those are often pertussis and influenza. The smaller aerosols are tuberculosis. You can get that with someone coughing in your face or being really close, or that person can cough on the environment. You can touch the environment and then touch yourself, and then you get sick. Respiratory hygiene and cough etiquette are a huge challenge, in particular when you think about the challenges with young children, because some of the masks aren't the right size for kids. You'd like to do some source control to put a mask on a coughing kid. So covering your mouth and nose when you cough or sneeze, and those who remember Sesame Street and The Count, coughing into your elbow is a great way to do your cough. Keeping 6 feet between yourself and that coughing person. And then really, the washing your hands is key. And so Gary Larson is one of my favorite cartoonists, and it always is the guy out of the men's room. It only takes a few minutes to go through the whole process. And so ding, ding, you didn't wash your hands. So let's dig in a little bit deeper what we're talking about, the whole big cluster kind of acute respiratory infections. Start with the viruses. So bronchitis, bronchiolitis, viruses, influenza bolded, because we can actually have antiviral treatments that are of benefit. We know that kids and adults have similar symptoms when they get viral infections. And this is from the Infectious Disease Clinics of North America in 2017. And this is for older adults, which is a nice way for you to go, okay, based on symptoms, what am I thinking of for this person having influenza versus RSV versus all of the other viruses? So one of the things to note is that influenza is one of those big ones with fever. Also some nasal congestion, difficulty breathing. Wheezing can be common. Cough is actually a little bit more common with the RSV. Sputum production is commonplace with flu, RSV, and human metapneumovirus. Those achy myalgias, actually rhinovirus seems to have a higher predilection in older adults for that achiness. Fatigue and hoarseness, more common kind of with influenza, and then some of these also with chest pain. So it's a nice little chart saying, hey, these are the viruses that are going around, and what do we need to think about? We know that RSV is the biggest player in the pediatric population and the most common cause for hospitalizations, but the elderly folks are also getting RSV. And many times in hospitals, adults aren't getting respiratory panels, and so you know they have a viral infection, but you're not sure what it is. We know that we're going to start on our RSV season about the same time as we start influenza season. We know that by the time a kid is 12 months of age, 2 out of 3 of those kids are already going to have their first episode of RSV. And by the time they get to 2 years of age, almost every kid will have had RSV. Preemies are the biggest concern, and immunocompromised kids, kids who have cardiorespiratory problems, those are the ones we worry about with RSV. Lots of hospitalizations, lots of outpatient visits. Frank Netter has this great photo, which, still from the old days, this is the best way to think about what does a kid look like with RSV. So when you think about Velcro and pulling Velcro apart, that's what that RSV bronchiolitis sounds like. The chest wall retractions, the croupy cough, the prolonged expiration, and the tachypnea that's out of sorts with what you see, and also the apneic episodes. Now, every institution has their own kind of algorithm for how to deal with bronchiolitis. And so we've developed a clinical pathway at Children's because we'd really like to keep kids out of the hospital for bronchiolitis. And the key things you need to think about with bronchiolitis is, one, is that sucking out the nose and decreasing the nasal congestion is an important thing. Oxygen therapy is also important. With good hydration and making sure kids are able to eat is the other part that's important. Steroids, nothing that really helps. Bronchodilators, what we do is if we test somebody and they have a good response, then we'll continue it, but it's not very common that bronchodilators will make a difference. The other challenge is that what do you do if the kid seems like they look like they're fairly well, but they might be able to be sent home? And so we've actually developed a follow-up system and a system to send kids home with oxygen to families and with good follow-up so that they don't have to be hospitalized. And that's something really to think about, how do you do that? We know that RSV and influenza have high rates of mortality, and if you take a look at this graph and you have the elders greater than 65 here and less than 1 year here, you'll note that influenza is the bigger player for death rates for people who are older. RSV is actually also very high, and this is one of those unknown numbers that people don't talk about. For cause of death, RSV, about 9,812 in these 2 seasons that we kind of compared for mortality. Now, my favorite virus is influenza, and this is person-to-person spread, and the small particle aerosols go through the air, and your dinner time trivia will be, how long is influenza viable to infect you if it's on a surface? And so if you have a steel or plastic surface, it can be from 1 to 2 days later that you touch it and you become infected, touch your mucous membranes. Cloth, paper, tissues, 8 to 12 hours. And on your hands, it's really quite short, but it has to be very high virus titer. We know that influenza will replicate in your columnar epithelium in the back of your throat. And once you're exposed and you're susceptible, you're going to get sick within 18 hours to 5 or more days. And usually it's about 2 days later. And many of you will remember who gave you influenza many times in your work setting. Well, that person was really sick and I was sitting next to him. Now I'm sick the next day. When you're a healthy adult, you will shed the virus through your nasopharynx and your nasal secretions anywhere from 3 to 7 days. So that's kind of the adult realm. Now, when you think about little kids, they become the epicenter of influenza because they're not quite as sick, they're running around, snotty nose, and they actually shed the viruses in higher titers, but also for a longer time period. And they can actually shed viable influenza virus for 10 days or longer. So you can become infected from that cute little kid who is the cesspool running around in your neighborhood for influenza. Now, the other part for age differences for influenza is that children, adolescents, and adults all have different manifestations of the same illness. And so children, one of the things that is a distinguishing characteristic is the toddlers may actually have vomiting and diarrhea as part of an influenza infection. Now, one of the misnomers that happens is someone says, I have the stomach flu, and it's not norovirus, but they actually may have, as a toddler, have influenza, actually the real influenza viral disease. Adults and elderly population, more of that, feel like a Mack truck hit you with a fever, myalgia, cough. You don't have those GI kind of symptoms, and that's an important distinction. And that's why one of the reasons that we have a difficult time saying someone has influenza-like illness when they're a child, because their manifestations may not be what we think about for adults and adolescents. This is taken actually from the South African Medical Journal, and it's a nice way to think about the diagnosis of influenza. And so they start with high fever, headache, myalgia, and dry cough. One of the comments with elderly population, you may add more of the mental status changes with confusion and drowsiness. So the question comes, when do you decide to do an influenza test or not? And many times our decision tree for an influenza test is, are we going to treat or not? Treatment for the person who has influenza, probable influenza, should happen as soon as possible. Our perspective at Children's is that if you are admitted to the hospital with influenza, even if it is 5 or 10 days later, you should get antiviral treatment, despite the fact that we talk about 48 hours is what the package inserts say for most of the antiviral medications. We also will treat kids who have influenza if they're a healthy child and they have an immune-compromised parent, or they have a sibling who may have cardiopulmonary compromise, and we want to try to keep that viral shedding down and get that kid as healthy as possible as soon as we can. And so this algorithm tree is actually quite a nice tree to take a look at as to what to decide to do. These are the antiviral medications, and I've taken them from the CDC website, and that's where I would refer you to go to the CDC website for any of the updates for what the dosing is. The most common medication we use is oral oseltamivir, and so the trade name is Tamiflu. Oseltamivir works against influenza A and B, and the recommendations really have been for any age for treatment. And so we've utilized it in very young infants who've been in neonatal intensive care unit, talking about the risk-benefit ratio outweighing that we really want to treat them with their influenza. One of the concerns we have with influenza with young neonates is that we're not sure of how much of the oseltamivir actually goes into the CNS. And so that's always been a concern that people have talked about and been concerned about. Chemoprophylaxis, the CDC talks about 3 months of age and older, and we try to limit our chemoprophylaxis and focus on vaccination, but knowing that you can't vaccinate under 6 months of age. Inhaled zanamivir is not as commonplace. One of the challenges with that is that people who have reactive airway disease may exacerbate their symptoms. And we also have a newer medication over the last couple of years, intravenous peramivir, which is used for 2 years and older for that population. These are all of the little things that talk about the details of how to dose people. And now we actually have a brand new medication which was FDA approved on October 24th, baloxavir marboxil, and FDA indication is 12 years of age and older, and this is a single dose. And the FDA package insert says it's single dose given within 48 hours of symptom onset with or without food, and I put the dosing there. So a single dose if you're 40 to 80 kilos is 40 milligrams. If you would be over 80 kilograms, it would be 80 milligrams. I've only seen some of the advertising and other kind of things that talked about $150 for the one pill. So it's hard to know what actually the real cost is, and that will be one of those things to look at if you're going to use this new medication to start, and remembering what the indications are for FDA for that group. So when I think about influenza, I really try to get it down to technology. So don't think of it as getting a flu shot. Think of it as installing virus protection software. So show of hands within where you work, how many of you have influenza vaccination as a condition of employment? Okay. How many of you don't? Handful. Do you work at the VA? No. Okay. So the VA is one of the places where they actually don't have that yet, but it is more commonplace for it being a condition of employment. We have it also at our institution for us. So two choices that you have. So you have the injectable vaccine, and then you have now available this year the live attenuated intranasal vaccine. Both of them will give you serum antibodies, the intranasal vaccine, opportunities for some mucosal immunity and question of cellular immunity. The efficacy rates really for all of the vaccines are all over the map. And the challenge is whatever virus is circulating in the community and how good of a match you have for what vaccine you chose. Important things to know for the inactivated vaccine, it's a dead vaccine. It doesn't have any live virus in it. The single dose administrative vials also don't have any thimerosal. The only vaccines that have thimerosal for influenza vaccine is if you have a multi-dose vial and it has a little bit of thimerosal as an antibacteriostatic. The live intranasal vaccine is cold adapted, so the idea is it's only going to replicate in your nasopharynx and not replicate in your lungs, which are warmer. So it's temperature sensitive also, so if it would happen to go down into your lungs, it'll be killed. And it's a weakened virus, and so it's not going to give you influenza. It may give you a little stuffy nose with the squirt. Both of these are made in chick embryos. There's a couple of vaccines that are made in insect cells that don't have any egg in them. One of the things to remember is that egg allergy is no longer a contraindication for influenza vaccination, so that's important to know. And then the indication really for inactivated vaccine is anyone 6 months of age and older, and then the live attenuated intranasal vaccine is 5 to 49 healthy people. So those are the viruses that you get to deal with, and those are the things that you can do. So what about the great bacteria acute infections? So rhinosinusitis, so sinusitis is a cesspool of its own, and I chose not to talk about it. I'll talk a little bit about strep pharyngitis, pertussis, and pneumonia. But I will give you this reference. And so this is taken from Clinical Infectious Disease in 2012. And it's a nice clinic practice guideline for acute bacterial rhinosinusitis in children and adults. And it's really helpful to go through to help give you ideas of what you can and can't do. The little graph in the bottom talks about what happens with a viral URI. And so one of the things to remember is that time zero of a viral URI, you're going to have some fever and be sick for the first couple of days, and that most people will have respiratory symptoms up to 2 weeks later. And so remembering that when you start thinking about when do I decide to treat for acute bacterial rhinosinusitis, it really needs to be a prolonged time period or having very acute symptoms of sinusitis. Now, you thought that sinusitis was tough to sort out, but pharyngitis is even more difficult. And it's actually the 6th most common reason that people come to ambulatory visits is because you have a pharyngitis or a sore throat. 10 million cases diagnosed annually, and the big player is really Streptococcus pyogenes or group A beta strep. So this is an ancient slide when they used to have all the really nice carousels and all the blue slides, which were the greatest things that we used. And this is 1910 to 1977. And the importance is the reasoning why we choose to treat group A beta strep pharyngitis. And so we had Streptococcus first classified in the 1930s. We started getting sulfas. Penicillins weren't available until the mid-1940s, and this was the death rate per 100,000 population. So antibiotics have really made a difference, and this was death specifically related to rheumatic fever. Now, we know that there's hotbeds of rheumatic fever. There's a couple of hotbeds within Utah where they have a certain strain circulating more rheumatic fever. Developing countries have more cases of rheumatic fever, and it's important to know that rheumatic fever is the important reason of why we choose to treat group A strep pharyngitis, that as well as the other complications. These are the incidences of rheumatic fever from the 30s through the 1990s where we had a handful of outbreaks, but heart disease related to rheumatic fever is anywhere from 5 to 30 million children and young adults if you look at it worldwide. So it's still a huge issue for group A strep pharyngitis. So here's some nice photos of that rash. And so remember, that rash is a sandpapery rash when you have group A strep. And I usually like to use the back of my hand to feel the rash because it's a little more sensitive feeling that sandpapery rash. This is a kid with a nice kind of beefy looking cheeks, has that little look, a little bit of slightly red lips. And then this is the throat with the palatal petechiae. You see a little bit of pus on the tonsils. The differential diagnosis, I think, about pharyngitis that looks like this is it group A strep? I'm going to do a culture or a rapid test for that. Is it adenovirus? Or is it Epstein-Barr? So is it mono? Those are the three big ones that I think about. Here's my differential diagnosis, and only one of those is going to have treatment, which would be group A strep pharyngitis. The study in JAMA in 2004 was done in a family medicine clinic in Calgary, and they had children and adults. And their question was, should you do throat cultures or should you just give people antibiotics if it seems like they have strep based on what their symptoms are? And so there's a modified Centaur score, which really takes a look at the symptoms of fever greater than 38, no cough, because that gives you a higher likelihood of having group A strep versus a viral illness, exudate and kind of cervical nodes, the tonsillar swelling or exudate, and then the age. And so younger age and that school age gives you a point. If you're an adolescent and a healthy young adult, that gives you a 0 point. If you're older, it actually decreases your points. So it was a way to give them a protocol to say, what's the likelihood you're actually going to have group A strep? Now, one of the things that they found is that really, if it seems like it's high likelihood for adults, you really should do a culture and then move on to treatment from there. South Africa had a nice, in their African Medical Journal, had a nice, in 2016, another nice algorithm to take a look at when you have sore throat, fever, difficulty coughing, and then halitosis. And so I would say that moms and dads are great at diagnosing strep in their kids, and many of them will say it smells like strep, and it does have a very distinctive smell. So the viral features that give you, it's unlikely to be group A strep is that, runny nose, that cough, conjunctivitis. Hoarseness is really associated with viruses, is not associated with bacterial infections. When it's more likely, doing a throat swab, and you can do symptomatic treatment, and then the treatment courses are the next components. So really, amoxicillin or penicillin really are the key drugs of choice. Many people in the past, I remember getting my shot of benzathine penicillin. We seem to have a little bit of a shortage here and there for benzathine penicillin. Cephalexin is a reasonable alternative. Clindamycin, we'll often use clindamycin for people who have recurrent strep pharyngitis and also to try to get deep into the tonsillar tissues, and so clindamycin is a reasonable choice. Azithromycin, the dosing is different than was in this infectious disease article, and it would be 12 per kilo once daily, then 6 per kilo for the next 4 days, the classic kind of Z-pack. And azithromycin really is not the optimal drug for group A strep pharyngitis. The other bacterial thing that we treat is pertussis. And so who knows if they've had pertussis? Who in this room, I've had pertussis. Does anyone? It was, one of the worst things in my life. And we know the challenge is that it starts out as a cold or URI, and that's when you're going to be the most contagious before you start getting that cough, which is going to be that kind of whooping cough for young kids, and then the worst cough of your life for adults. It's also been known as the 100-day cough, and it's a very long time period where you're going to have the cough. It's a gram-negative pleomorphic bacillus. Humans are the only known host, and even though it's Bordetella pertussis, the Bordetella bronchoseptica is what kennel cough is in dogs, and so there's really not a transmission between the species. Your contact is with respiratory secretions, and the most contagious stage is really through URI stage. Now, this is a reference that's from the New England Journal of Medicine. There's a nice video. If you want to do some teaching with your colleagues in your clinic, is what it really sounds like for whooping cough in an adult. And this is an adult who was a 64-year-old guy. He was admitted because they thought he had an asthma exacerbation. And he had been treated with steroids, been in emergency time multiple times. He was having some chest tightness, difficulty eating, and he actually had pertussis. But he also unfortunately exposed lots of his family members because he wasn't treated appropriately. For the adolescent and adult, their cough lasts up to 3 weeks and more, 9 weeks in half of the people. Whoop is not as common, so it's not that cough, cough, whoop. Oftentimes, adolescents and adults will have post-tussive emesis after they have their coughing episode. Missing school, missing work is high, and then disrupted sleep is important. We know that in a family, it's usually the young kids who will get pertussis from those adolescent and adult family members. And the classic history that I get when I have an infant admitted with pertussis is finding out which family member had a really bad cough that they thought the worst cough of their life. And many times recently, it seems as if they've been in healthcare. And so we had a mom who was a physical therapist who had a really horrible cough, exposed to lots of patients, and then her infant came in with pertussis. This is taken from Infectious Disease also in 2012 with a nice way of taking a look at what you would decide to do for treatment and diagnosis. And so there is a poor man's way of doing, in young children, doing a white count. And one of the things with a white count, if you have a very, very high, a white count that's high with lots of lymphocytes predominant, that in the right setting is a really good sign that someone may have pertussis. The ability to do PCR is important. Serology is done mostly in the state health department and other health departments for identifying outbreaks. Serology is not the ideal for you to use unless it's been a long time, and the challenge is that if you've been vaccinated with pertussis vaccine, it may be positive because of that versus actually having pertussis. So I have a couple of pages of what are clinical pearls for you to think about pertussis, because it's something that we forget to think about when we're treating someone for another acute respiratory infection. Key thing is that fever isn't around, it's afebrile. Cough has continued to increase. The beginning of the illness has kind of that coryza, that runny nose, but it doesn't become that white or green snotty nose as it progresses. So it really is a clear nasal discharge. The paroxysmal cough is cough, 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 and then you run out of breath, and then you do that whoop. We know that infants have the exposures to adolescents or adults. And the other part for adolescents and adults is when they cough, it's not productive. It's not what you expect in viral bronchitis where you sometimes will cough something up, but the cough in pertussis is not a productive cough. It's a dry cough. The other interesting things that adults and adolescents may have is in between their coughing episodes, they have periods of sweating. So it's almost as if you're really stressed out and you're ready to cough and you start sweating and getting anxious and then you have another coughing episode. And that should make you think about pertussis. PCR is useful in the first 3 weeks. We don't do culture anymore, only done in certain settings. Serology is not helpful in with whole cell vaccine or acellular vaccine. We don't use DFA anymore and discourage use of ELISA. So you think pertussis, doing a test for it is important because that will help you with the epidemiology of treating the family or other potential contacts. This is taken for the American Academy Pediatric Red Book, and so the important thing to know is that azithromycin really is the drug of choice, and the thing that I'd like you to just remember is that if you're under 6 months of age, you get azithromycin 10 milligrams per kilogram per day for 5 days compared to what the classic dosing is. So it's a higher dose that's required in those kids under 6 months of age. Erythromycin is the one that is associated in young children with idiopathic hypertrophic pyloric stenosis. There's some concern, a small concern that azithromycin may do the same kind of thing, but erythromycin is known to do that. Clarithromycin doesn't taste as good, and then actually trimethoprim sulfamethoxazole is an alternative. When I've been stuck with what do I need to use when someone can't take azithromycin because of prolonged QT syndrome or other kind of medications that interact, can't take erythromycin, clarithromycin, or trimethoprim sulfa, there is some in vitro data talking about use of levofloxacin for pertussis, but it really would be wise to get counsel from kind of state health departments and local health departments for that if you need to. And I really think about this, not vaccinated, no kisses, and really pushing for adults to keep kids healthy. One of the things that we know that's been recently, over the last 5 years or so, is when pregnant women are getting pertussis vaccination with each pregnancy, we're actually starting to see a decrease in infant pertussis. And that's one of the big benefits of doing that for women has been. We also know that there haven't been any untoward effects for women, maybe a little bit more arm soreness, but no no other kind of adverse issues that we worry about. So, pertussis. So let's deal with community-acquired pneumonia in adults. So productive cough, pleuritic pain, dyspnea. When you listen to the lungs, you have the crackle, increased respiratory rate, febrile. Someone all of a sudden is very ill. We know that adults compared to children are much more likely to be bacteremic with their pneumonia. Children are less likely to be bacteremic, in particular with Streptococcus pneumoniae. And when you take a look at the study from 2016, you can see global community-acquired pneumonia throughout the world, bunch of viruses. The typical strep pneumo still is the biggest player, H. flu, a little bit of Staph aureus, Legionella lower, Mycoplasma a little bit higher, and Chlamydiophila a little bit lower. For adults in outpatient treatment, so Infectious Disease Society America, the American Thoracic Society, drugs of choice for community-acquired pneumonia in adults. So community-acquired, they're going to be staying in the ambulatory setting. Macrolides or tetracycline for healthy patients who have no risk factors. Comorbidities, people talk about using respiratory fluoroquinolones or a beta-lactam plus a macrolide. Now, and that's the U.S. kind of recommendations. Europeans, for outpatient use, really talk about amoxicillin or tetracycline for their top choice, with macrolides as kind of the second choice with only penicillin allergy. And this for adults, for Europeans, is much closer to what we use within children. And so they've chosen to use amoxicillin as their top of drug of choice versus in the U.S. using macrolides. And in South Africa, also using amoxicillin as the top choice. These are the dosing for community-acquired pneumonia for adolescents and adults for the azithro, chlorithro, doxycycline. If you have risk factors, going through all of oxycins, moxifloxacin, gemifloxacin, levofloxacin, the amoxicillins, and those others for your drug choices. Now, when you think about the pediatric groups, it's a little bit of a difference in what's the etiology based on your age. And so 0 to 2 years of age, 3 to 4, 5 to 8, and 9 to 16. There's a lot of unknowns. It's sometimes a challenge to identify what the cause of a pneumonia is in children. The purple is pneumococcus, and you can see that's a consistent player throughout the entire group for pneumococcus. Mycoplasma, which is red, and chlamydia, which is green, really starts when you get to be the school age. And so thinking about pneumococcus as what you need to cover for the pediatric population throughout the whole spectrum of pediatrics, and then as you get to the school age and a little bit older, that's when you need to start thinking about the atypical organisms such as mycoplasma and chlamydia. Again, the Infectious Disease Society of America put together some guidelines which are currently under review for update, and here's really what the punchlines are. Amoxicillin, amoxicillin, amoxicillin. Really for pediatric community-acquired pneumonia, that's the ideal drug of choice. Mild to moderate, you could use it twice a day, 90 milligrams per kilogram per day, divided twice a day. Length of treatment course, we make things up. We kind of say, is it, 3, 5, 10 days. We like those numbers. 10 days have been most commonly studied. There are some places that have studied 3 days in developing regions. When you're hospitalized, it's a different kind of challenge, but 10-day course is commonly what you would use. First line of treatment for previously healthy, immunized school-age kids, adolescents, really should be amoxicillin. Those kids who may have community-acquired pneumonia thinking that it's caused by mycoplasma, that's where using the macrolide antibiotics such as azithromycin or clarithromycin might be indicated. Very rare to have macrolide-resistant pneumonia, and there's some limited data that, using that they'll have a shorter fever and a cough if they use a macrolide. Azithromycin for 5 days, doxy. One of the things, and this was in 2011, talking about doxycycline for greater than 7 years of age. In our American Academy of Pediatrics Red Book, we've actually gotten rid of the doxycycline concerns because there hasn't been any evidence showing that there really is dental staining with short courses that you would have in pneumonia. So one of the things that in the Red Book that we've taken out is any of those that give you any reason to not use doxycycline. The biggest one is when we think about tick-borne illnesses, and so Rocky Mountain spotted fever, doxycycline, no matter what age, is important. And so we're really trying to get that out, that doxycycline can be used for short courses in children. And so that's a new kind of recommendation that we have and that we're working to try to increase. So one of the things for trivia, gorillas actually get RSV. So I was lucky enough to go to Rwanda, and I taught for a while, and I went with the veterinarian, and so she was doing nasal swabs to find RSV in the gorillas, and they have the same epidemiology as small children. And then the Sphinx knows all, and so I will close speaking and open it up to questions about anything with acute respiratory infections. If you would please come to the mic and ask your question, and then we'll try to have some dialogue about what you found works for you. Questions? Anyone? Who needs to get a flu vaccine still? I think Anne-Marie probably has. We have some available, potentially.
Hi. At what point would maybe a bronchiolitis or bronchitis, do you get concerned about it being bacterial? Like, how long does the cough and productive cough last? At what point do you say, this isn't normal for a virus? Is there a point? I know with sinusitis, there's some guideline for that as far as if you get a fever, if you aren't responding, that kind of stuff. Is there something for the respiratory?
So what's the time frame of the illness progression? So with viral infections, URIs, so they will have a progression of up to 3 weeks. So one of the things that I usually ask families, as they have their illness and they still have their runny nose and green snotty nose and they're afebrile and doing well, then with another fever spike or something new, makes me concerned, should I get a chest x-ray or assess for actually a superinfection with bronchiolitis or kind of other bronchitis issues. These are in the healthy folks. So those of you who deal with people with chronic obstructive pulmonary disease and those kind of challenges, that's a different kind of story. But the natural progression is really a couple of weeks of illness for the regular virus. But one of the other points about when you start worrying, so kids who are admitted to the hospital with pneumonia, one of the things when you have pleural effusion, which really is a nice serous reaction, we know that those kids will have a prolonged fever. So they'll be better, they get their treatment. Many times we'll use oral antibiotics if we can in hospital. They're not on oxygen anymore, they're starting to ambulate. We send them home, and then the family calls and said they still have a fever 2 weeks later. If they have a pleural effusion, we're okay with that as long as they continue getting better. And so two things. One is, what do they clinically look like for you as they're improving? And then, is the fever continue to be less frequent, so 1 fever per day? And a lot of that will be your own assessment of how worried you're going to get with that. But it does last a long time for having kind of viral illnesses. So in the center.
Hi, thanks for your talk. My question is about giving Tdap to family members of women who are pregnant. Is the recommendation, as long as the family members have received a Tdap within the last 10 years, then they're okay to be around a newborn? Or
so the question is, what really are the Tdap recommendations? So one of the Tdap recommendations is that once in your adult life, a Tdap. Actually, once 11 to 12 years afterward, if you're just a regular, old person. If you're a pregnant woman, that's on an annual basis. But there's no recommendation officially from the ACIP to have repeat Tdaps every 10 years. It does say TD or Tdap every 10 years, and so either one is fine. There has been controversy within the ACIP about the cost of the increased cost of Tdap versus TD. There's also been conversation about the TDs going away and we don't have as much. And so there's no harm in getting more frequent Tdap, but the official recommendation is once in your adult kind of life. And for our hospital, we have made Tdap now also a condition of working, making sure that we're trying to keep Tdap down, pertussis down as much as we can. So it's anytime after 11-12. The challenge with Tdap is that, and any other pertussis vaccine, is it doesn't give you lifelong immunity. So vaccine doesn't give you lifelong immunity, but also it's important to know that getting pertussis does not give you lifelong immunity. And your immunity lasts maybe 5 to 7 years for wild-type pertussis. So you still need to get antimicrobial prophylaxis for exposure, which is kind of a challenge and hard. So thanks for that question to clarify. It's great.
Hello.
The Price is Right. I feel like it's The Price is Right. You're coming down for that. Yeah. So go ahead.
Are there any recommendations to treat other types of strep besides A obtained from the pharynx?
Yeah, so what about the other kind of strep or other kind of issues? And so the real recommendation for throat cultures is to do a selective media only for group A beta strep. And one of the problems comes when you have C or something else, and it's information I actually don't want to know because I don't really know what to do with it. So group A beta strep is good. And the other thing that will sometimes happen is you get a throat culture, and then I get a call because someone said, I found Neisseria meningitidis on the throat culture. And so I'm challenged with what am I going to do, because we know that it can be carried in your nasopharynx. And so there's people will go one way or the other. Well, should you treat the N-meninge with rifampin for chemoprophylaxis? But really, the idea should be looking only at group A beta strep for your throat cultures. The other organism to be concerned about and wouldn't be shown on a throat culture is particularly an adolescent or a young adult who has the worst sore throat of their life, and they have neck pain. And so that is when we think about fusobacterium, and so Lemir's disease, where they have fusobacterium, sometimes bacteremia, and they may have showering in their lungs. But the two things I look for, really, really horrible, horrible sore throat, and then also having neck pain, and they can get thrombophlebitis. But you wouldn't get it on a culture either, so.
Thank you.
You guys are doing pretty good for a Saturday afternoon, so. Good.
Hi, thanks for your talk. I'm just wondering if you could speak to kind of like a chief complaint of.
Yeah. That's fine. You can face that direction. I'll hear you still. Go ahead.
Okay, I'm just wondering if you could speak to a little bit, just briefly, on somebody who comes in with a chief complaint of chronic cough, like a regular cough, or they think that they've been having a regular cough for the last week or so, and what you would do.
So when I think about chronic cough, so one of the questions will be, what's the age of the person? So I'd want to know. The other one with the chronic cough is, and specifically with age, thinking about small children who put things in their mouth and it's not supposed to be in the right place. So that's one. What is going on in the back of their nasopharynx for kind of a chronic drip, giving them a chronic cough? Pertussis, I always think about pertussis for a chronic cough. What other things are they exposed to in their environment for a chronic cough? And then what you can do for symptomatic kind of relief, and thinking about that allergy end along the way. There was a recent study talking about the use of steroids, and one of the folks analyzing that study, steroids are actually prescribed pretty frequently, and you shouldn't. There's nothing that they, make a difference for these viruses and bacteria. Unless you have an asthma exacerbation, then steroids will make a difference. But it was actually pretty surprising. I think it was 1 out of 3 antibiotics had a steroid along with them to make you feel better. And so that's a little bit of a challenge. But I think that's a challenge with, what are you going to do and it's probably viral, but how do you do the symptomatic relief? But think pertussis in the back of your mind and going, could it be that? Is there any exposure? And then the other stuff will follow. So. I think we're good. All right, thanks, gang, and thanks for hanging in there.
We will wait a few more minutes before we begin this next one anyway, just because the one upstairs is maybe winding up. So go use the restroom if you need to, and we will, or just stand up if you want to. And we'll start this next one in like 9 minutes.
Did you need to do anything with the poll?
Yes. Okay, everybody, we're going to go ahead and get started with our last talk of the day. I would like to introduce Dr. Tim Jenkins, who is an infectious diseases specialist, the director of the Antibiotic Stewardship Program at Denver Health, and an associate professor of medicine at the University of Colorado School of Medicine. For the last 10 years, he has been involved in the development and execution of quality improvement initiatives, research, and policies to improve antibiotic use at the local, state, and national levels. He was a co-author of the Infectious Diseases Society of America guidelines for implementing antibiotic stewardship programs, and he is also a member of the NIH Antibacterial Resistance Leadership Group. Please welcome Dr. Jenkins.
Thank you very much. Good afternoon, everybody. Welcome to the last talk of the day. It sounds like it's been a great conference so far. So I was asked to talk about the duration of antibiotic therapy for common infections, which even for an infectious disease doctor is probably one of the least sexiest topics you could ask somebody to give a talk about, as compared to something like new antibiotics coming down the pipeline, C. diff, other talks you've had today. However, I think it's a hugely important topic, so I'm glad you guys decided to come to this. And I tried to make this as useful and practical and interesting as possible. So if you have been using the Kahoot audience response system, I have a number of questions throughout, so please plan to participate if you're interested in doing that. So as we get started, I have no conflicts of interest to disclose. And so at the end of this talk, my goal is for you guys to be able to explain the relationship between duration of antibiotic therapy and unintended consequences of antibiotics, to identify some of the recent evidence in our current national guideline recommendations regarding the duration of therapy for common infections, and then lastly, to really just go out and prescribe evidence-based guideline recommended durations of therapy in your own clinical practice, which is what we should all be striving to do. So in getting your phones out, the first question is really just a straw poll of the audience. So in my clinical practice, the most frequent duration of antibiotic therapy that I prescribe is, and so this is sort of looking for an average, your clinical practice. And if it's not exactly one of those, just pick the one that's closest to it. So we'll go to Kahoot here, and I think I need to give you guys a minute to type in the PIN number. So I have a 5th grader who saw me putting these Kahoot questions in, and he got so excited because he said they use Kahoot all the time in his class. And he said that his nickname is Bob the Cat, and he asked me what mine was. And I said I had no idea, but I need to think of a good one. All right. Anybody need any more time? Raise your hand if you need another second, or otherwise we will go ahead and start here. All right, so on average, the most frequent duration of antibiotic therapy that you prescribe. Okay, so it looks like 7 days is probably the most common, but and then next most frequent is a combination of either 5 days or 10 days. And then less frequently, 14 days. So kind of a little bit all over the spectrum, and this is just some background information, and we'll talk a little bit more about this here as we move forward in the talk. So I want to start a little bit with why we care about duration of therapy. So as some of you may know, back in 2015, the Obama administration launched what was called the National Action Plan for Combating Antibiotic-Resistant Bacteria. So this was in response to really a worsening global crisis of antibiotic-resistant bacteria that we continue to be in. And this was actually continued to be supported by the Trump administration, so bipartisan support for this plan. And the goals of this plan, 2 of the goals were by 2020, so very soon now, to reduce inappropriate or unnecessary antibiotic use in the outpatient setting by 50% and unnecessary or inappropriate antibiotic use in the hospital setting by 20%. So these are very lofty goals by 2020. And one of the major strategies for trying to accomplish these goals is by improving our stewardship of antibiotics, so strategies to improve antibiotic use. So antibiotic stewardship can be defined in a number of ways, but I like this definition. So it's really a patient-level practice where we're trying to maximize the chance for a good clinical outcome for each individual patient by ensuring that there's an appropriate indication for antibiotics, so the right indication, and that when there is an indication, they're prescribed the right antibiotic at the right dose and for the right duration of therapy. And I can tell you that we've had a really hard time with this one, ensuring that there's an appropriate indication over the years. So for the last decades, we've had a very difficult time trying to reduce prescribing rates for conditions where we know antibiotics don't help, such as acute bronchitis or viral pharyngitis. We still have very high rates of prescribing for these conditions. But I would argue that by addressing duration of therapy, we can actually make a much more immediate impact in reducing overall antibiotic exposure, unnecessary antibiotic exposure, that'll move us towards these National Action Plan goals. So I want to just touch base about what treatment durations of clinical practice are in the Denver Health System. So we pulled data from the Denver Health Ambulatory Care System. So we looked at prescriptions from our outpatient clinics, our emergency department, and urgent care center. And so we looked at over 20,000 prescriptions and simply looked at the durations of therapy that providers were prescribing. And what we found is that just over half were actually prescribing, of all prescriptions, were 10 or longer days of therapy, so quite prolonged durations of therapy. And this was actually more common in the outpatient clinic, so in primary care, as compared to the emergency department or urgent care. So primary care clinicians were really very frequently prescribing 10-day or longer durations of therapy. And so what would happen if we could get providers to shift this and prescribe shorter durations of therapy? So this is sort of just a hypothetical schematic of what could happen. So if we were getting providers to use 10-day courses instead of 14-day courses, or 7 instead of 10, or 5 instead of 7, that reduces overall antibiotic exposure on the order of 30%. And I think a lot of us wouldn't really think too much, well, is there really a big difference if I prescribe 5 days or 7 days? But it really is. That's a 30% reduction in antibiotic exposure for that patient. So again, I think if we can incrementally shift, and the message here is that these incremental shifts in durations of therapy can really achieve substantial reductions in antibiotic exposure. And that's one of the reasons for talking about this here today. And so as we talk about optimizing the duration of therapy for patients, our goals in doing this are twofold. So one, to maximize the chance of curing the infection. We don't want it to treat too short. We want to make sure we cure the infection, but we also don't want to treat too long in order to minimize unintended consequences of antibiotics. And you guys know these well. So selection of antibiotic resistance, C. diff infection, adverse drug events, and drug interactions. We're learning more and more about the potential health ramifications of disrupting the microbiome, especially in early childhood. And then healthcare costs and patient burden should be on here as well. So we're really trying to reduce all of these unintended consequences. And I want to just highlight several examples from the literature that kind of demonstrate this association between duration of therapy and resistance. So the first, for the association between duration of therapy and resistance, 2 studies I just wanted to briefly mention. These are from the inpatient setting. So one was a study of ventilator-associated tracheitis in children. And so they looked at patients who got a less than a 7-day course or a 7 or greater day course of antibiotic. And what they found was that those who got the longer duration, the greater than 7 days, had more than a 5-fold risk of developing colonization or a new infection with a multi-drug resistant bacteria. So the longer durations of therapy selected for resistant organisms. A similar finding in a randomized trial that was published about 15 years ago now in adults that looked at randomized patients to 8 versus 15 days of antibiotics. So there was no difference in the cure rates between 8 and 15 days of antibiotics. However, in the patients who did develop recurrent infections, the patients in the 15-day group were significantly more likely to have infection with a multi-drug resistant bacteria. So resistance doesn't tend to develop at the site where we're treating the infection. It tends to develop in the intestinal tract where the antibiotics wipe out antibiotic susceptible bacteria, but then the antibiotic resistant bacteria that are not killed are then left to promulgate and become the dominant species and lead to colonization and subsequent infections. So that's called selective pressure for resistance, and the longer we treat, the more selective pressure for resistance there is. There's a very clear duration between duration of antibiotic therapy and C. diff. So this was a study of over 10,000 hospitalized patients who were receiving at least 2 days of antibiotics in the hospital. And what they found, so they used the group that got less than 4 days as the reference category. Those who got 4 to 7 days of therapy had about 1.5 or 1.4 times the risk or hazard of developing C. diff as those who got less than 4 days. Those who got 8 to 18 days had a 3-fold higher risk than the less than 4 day group. And those who got greater than 18 days had almost 8 times the risk of developing C. diff infection as the people that got the short antibiotic course. So there's a very clear dose-response relationship here between duration of antibiotic therapy and C. diff. And then just the last example I'll cite is the association between duration of therapy and adverse events. So this was a nice study published out of Johns Hopkins recently that looked at almost 1,500 patients who were getting at least a day of either an oral or an IV antibiotic in the hospital. And the first fascinating thing they found was that 20% of those patients experienced an adverse drug event that was judged to be related to the antibiotic. So I think this just highlights that antibiotics are not benign drugs like sometimes they are thought to be. And there was an association between increasing duration of therapy and increasing frequency of adverse events. And that's not really surprising. It makes intuitive sense that the longer you're on a drug, the higher your risk over time of an adverse drug event might be. So the message here that I'm trying to build the case for is that for any given infection that we're treating, we should be striving to prescribe the shortest effective duration of therapy. So I think that's the key phrase, the shortest effective duration of therapy. Because by doing that, we're not compromising clinical outcomes. We're still maximizing the chance for a good clinical outcome, but we are mitigating or minimizing the risks of all of these unintended consequences, both in the inpatient and outpatient setting. So going forward now, I wanted to talk a little bit about some specific cases. So I sort of have put some cases together in board-style format to try and keep you guys engaged and interested. So we'll have a brief case vignette and then a question. And then we'll look at some of the evidence behind duration of therapy and current national guideline recommendations for duration of therapy. So the first case or question number 2 is that this is a 23-year-old healthy woman who presents with 7 days of a cough, sinus pain, and congestion. Her sinus pain improved at first, but notably has worsened over yesterday, and she's feeling more ill when she sees you today. So her vitals are pretty unremarkable, but she appears uncomfortable, and she's got moderate right maxillary sinus tenderness to palpation, some clear nasal discharge. And as many of your patients probably will tell you, they've received antibiotics in the past for sinusitis, and she's requesting another one because they've worked for her in the past. So the question is, what is the most appropriate management for this patient? Would you prescribe nasal saline rinses and symptomatic relief, or a 5, 10, or 14-day course of antibiotics? And we will go to our next question. Bob the cat is not on here, but All right, so actually the majority of you said that you would not prescribe an antibiotic, but would prescribe nasal saline rinses and symptomatic relief. And then the next most common answer was a 5-day antibiotic course. So to me, the correct answer here is a 5-day antibiotic course, because this case actually meets criteria for acute bacterial sinusitis, specifically because she was initially getting better and then developed worsening of symptoms. And we'll talk a little bit more about that here. So what do we know about acute sinusitis? We know that 90% or more are viral in etiology, 10% or fewer are bacterial in etiology. And there are really 3 clinical criteria that predict acute bacterial sinusitis. So these are our 3 diagnostic criteria that you should be using in clinical practice for acute bacterial sinusitis. So no improvement or worsening symptoms by 10 days. Severe symptoms or fever lasting more than 3 days, or like our patient had, initial improvement and then worsening. And that's because this is suggestive of bacterial superinfection of likely an initial viral sinusitis. So despite the fact that we know that 10% or fewer of these cases are caused by bacteria, in a recent study by one of our ID fellows at Denver Health, antibiotics were prescribed in 90% of visits for sinusitis. So we are way over prescribing antibiotics for this condition. And I just want to share with you some data from her study, and so bear with me as I walk you through this. So she actually looked at prescribing practices for both sinusitis and pharyngitis. So the sinusitis are the gray bars here, the pharyngitis are the white bars. And so she looked at whether there was an appropriate indication, whether the appropriate antibiotic was selected, whether the dose was right, and whether the duration of therapy, whether these were all concordant with our internal Denver Health guidance. And if any of those weren't, they were classified as inappropriate or suboptimal. And what she found was that 80% of prescriptions for sinusitis were either inappropriate, not indicated, or suboptimal. And these were the various reasons. So almost half of those, there were no diagnostic criteria for acute bacterial sinusitis met, or at least none that were documented in the medical record. But what was really interesting to us was that even if an antibiotic was indicated, the duration of therapy was 10 days or longer, so longer than our recommended guidance, which at Denver Health is 5 to 7 days, and that's mirrors national guidance as well. So we're not only diagnosing it incorrectly, we're treating it for longer than recommended when we're treating it. Interestingly, for pharyngitis, you can see that excessive duration of therapy was never an issue, so no cases. So one of the most common prescribing error for pharyngitis was actually dosing errors. So very different prescribing errors when we looked at these 2 infections, which was an interesting finding. So the CDC recently published this study where they looked at practice patterns in relation to national guideline recommendations. So for the vast majority of cases of sinusitis, the typical case, 5 to 7 day antibiotic courses are recommended in our national guidance. But what the CDC found in this national study was that 5 to 7 day courses in clinical practice were prescribed in fewer than 10%, and greater than 90% of patients received 10 or more days of therapy. So substantially longer durations of therapy. So again, if we could shift from 10 days to 5 to 7 days, that's a 30 to 50% reduction in antibiotic exposure for each of these patients. And that could be a huge reduction in antibiotic exposure on a population level. So the message for sinusitis is twofold. We need to do a better job diagnosing it with the diagnostic criteria for acute bacterial sinusitis. And when we prescribe antibiotics, so if you're a high prescriber for sinusitis, you can still improve care of your patients by reducing the durations of therapy you prescribe if you tend to be a 10 to 14 day prescriber. All right. Next question. So this is a 72-year-old man who complains of new onset cough, shortness of breath, and right pleuritic chest pain that's fairly sudden in onset over 36 hours. He's a longtime smoker. He's got a low-grade fever, non-toxic appearing, but he's coughing vigorously, and on exam he's got right basilar crackles. And so you send him for a chest x-ray. His chest x-ray confirms a right lower lobe pneumonia, as you suspected. Clinically, there's no effusion there. And so you opt to treat him as an outpatient and prescribe doxycycline, and he's an adherent patient. He said that he'll call within 24 hours if he's not improving. So the question here is, what is the most appropriate duration of therapy for the treatment of this pneumonia? All right. So the majority chose 7 days. About a third of those of the majority chose 5 days, and one person would go longer at 10 days. Nobody, I'm happy to see, would prescribe 14 days, so that's excellent. We'll talk a little bit about the data here for community-acquired pneumonia. So national guidelines for community-acquired pneumonia actually recommend a 5-day course of antibiotics, both for inpatients and outpatients, for patients who are clinically responding to treatment. This is one recent study that came out after the current national guideline, which was published quite a while ago. An update of that guideline is in process. But this was a nice randomized trial that looked at different durations of therapy for hospitalized patients with community-acquired pneumonia. So these patients were randomized to an intervention or usual care, a control group. So the intervention included a minimum of 5 days of antibiotic therapy, but discontinuation of antibiotic therapy when patients were afebrile for 24 hours and met other few signs of clinical stability, such as absence of tachycardia and so forth. And so the median duration of treatment in this group was, in fact, 5 days. And you can see with the interquartile range here, the vast majority of patients got very short courses of therapy, less than 7 days. And in the control group, or usual care, the median duration of therapy was 10 days. And if you look at the differences in clinical outcomes, so here is clinical success at 10 days. So this is actually numerically higher in the intervention group. So shorter courses of therapy appeared to do better. This was not statistically significant. And even out to 30 days, no significant difference in clinical success rates with a median of 5 versus 10 days of antibiotic therapy. So no clear benefit of extending duration of therapy in pneumonia. And they also looked at symptoms. So these are symptom scores. The higher the score, the worse the symptoms. And you can see that there is no improvement in symptomatology by giving a longer duration of antibiotic therapy either. So this is, I think, pretty rigorous data that suggests that long durations of antibiotic therapy, even for patients sick enough to be hospitalized, are generally not necessary. So how are we doing in clinical practice compared with these national guideline recommendations? So the Infectious Disease Society of America guideline recommends 5 days for clinically responding patients. But in a recent, very large national study of prescribing practices, the median duration of therapy was 9.5 days, so almost twice that long. And the guideline also says that 7 or more days are really rarely necessary. And in this national study, 2/3 of patients were treated with greater than 7 days. So again, the message here is that we really have a lot of opportunity to shorten durations of therapy for a common condition like this for pneumonia, really both in the inpatient and outpatient setting. And I want to just highlight that it's actually not that hard to change provider practices with respect to duration of therapy. This was a study that we did at Denver Health where we simply provided providers with a guideline for how to treat these patients. So we sat down with our pulmonologists, our hospitalists, our pharmacists, and we developed a multidisciplinary guideline that included a recommendation for 5 days of antibiotic therapy, presuming the patient had clinically responded. And we looked at durations of therapy before and after that guideline was implemented. So this is the before period, the baseline period. You can see that our average duration of therapy was 10 days, and that in the intervention period after we implemented this guideline, this reduced to 7 days. So again, a 30% on average reduction in antibiotic therapy simply by providing providers with specific guidance. So I think for those of you that lead clinics, that are involved in hospital QI projects, that's a very important message, that providers respond very well to specific institutional or local guidance. I also want to point out for those of you that see patients in the hospital setting that short courses of therapy are thought to be effective for hospital-acquired pneumonia, healthcare-associated pneumonia, even ventilator-associated pneumonia as well. So this is the Infectious Disease Society of America guidance for hospital-associated pneumonia, and you can see that they recommend just a 7-day course of antibiotic therapy, and that's a strong recommendation, albeit with fairly low-quality evidence. And this was an interesting excerpt from the text, which says that the evidence suggests that the duration of less than 7 days doesn't reduce the benefits of antibiotics, but it does, the shortened duration does reduce side effects, C. diff, antibiotic resistance, and cost. So those are the things we talked about at the beginning of the talk, of sort of reducing these unintended consequences of antibiotics. So for community-acquired pneumonia and healthcare-associated pneumonias, 5 days of therapy, 7 days of therapy are certainly tend to be effective. All right, next question. So this is a 47-year-old woman with diabetes mellitus who presents with 3 days of progressive right lower extremity redness, swelling, and pain. She had an episode of cellulitis about 18 months ago in the same leg on which she's symptomatic on. She has a low-grade fever and has findings consistent with cellulitis of the ankle and calf, and also has tinea pedis. So in addition to treating her tinea pedis, which we should all be doing in the setting of cellulitis, you prescribe her cephalexin. And so the question is, what is the appropriate duration of therapy for a diabetic with a second episode of cellulitis? Last one being 18 months ago. 3 days, 5 days, 10 days, or 14 days? Whitney, you didn't see, but you're first in the polling right now. Congratulations. All right, excellent. So the majority of you picked 5 days. Some picked an even shorter course, 3 days, and then some picked a longer course of 5 days. And I hope to convince you that 5 days would also, for this case, be the recommended duration of therapy. So these are our national guideline recommendations for duration of therapy in cellulitis. For cellulitis, it's 5 days. And that's a strong recommendation based on high-quality evidence. I also wanted to mention cutaneous abscesses. So the current recommendations for the duration of therapy for skin abscesses is 0 days. It's drainage alone. Unless, of course, the patient has fever or other systemic symptoms, then it is recommended to give antibiotic therapy. For the typical simple skin abscess that you might see in the primary care setting with no systemic symptoms, drainage alone is the current recommendation. And we'll talk a little bit more about that. So this is one of the studies, and this was published after the most recent guideline came out, but this was a large study, over 650 patients who had either cellulitis, abscess, or a wound infection. They got randomized to 2 different treatment durations of antibiotics, 6 days of a newer drug called tedizolid, and 10 days of a drug called linezolid, so both in the same family of antibiotics. And this shows the proportion that had clinical success at the end of therapy. And you can see that those were very similar between the 2 groups, and clinical success at the end of follow-up 30 days after the end of therapy. And you can see that the 6-day course performed just as well as the 10-day course, and that the tedizolid was non-inferior at both time points. And that went for all of the different subgroups. So cellulitis, there was no difference. Skin abscesses, there was no difference. The majority of these patients were hospitalized. So short courses of antibiotics for cellulitis, even hospitalized patients with cellulitis, appear to work very well and are advocated in our national guidance. And so there is this ongoing controversy, or this has been an ongoing controversy, of whether we need to give antibiotics after drainage of a simple abscess. So many people have advocated not giving antibiotics to these patients. And two large randomized trials have come out in the last 2 years that I think really answered this question. And if you saw my talk on skin infections last year, I did mention this particular slide, but it's relevant to duration of therapy, so I wanted to share it again for those of you who didn't see that talk. So this particular randomized trial was over 1,200 patients who were randomized to either 7 days of trimethoprim sulfa or Bactrim or placebo for treatment of skin abscesses that were at least 2 centimeters in size, and all of these patients had their abscesses drained. And I think the average size of these was about 3 centimeters. And this was clinical cure 7 to 14 days after the end of treatment, either the placebo or the antibiotic. And you can see that the antibiotic performed better than placebo by about 7 percentage points, so 80 versus 73%. So not a huge difference, but clearly better, statistically better, and in the per protocol population, also about a 7% improvement in clinical cure rate. So not massive, so it looks like actually drainage by itself does work in the vast majority of cases, but antibiotics do add an incremental benefit. And the really interesting thing was looking at some of these secondary outcomes. So the patients that got the antibiotic as opposed to the placebo had fewer additional drainage procedures. They had fewer skin infections at different sites during the follow-up period, fewer infections in household members, which was fascinating. And there was a statistical trend towards fewer hospitalizations. And interestingly, there was no difference in adverse events in this study between those who got the antibiotic versus placebo. So the upshot here is that now 2 large randomized trials have shown us that a short course of antibiotics after abscess drainage does appear to improve clinical outcomes. So I think our current national guidance of giving no antibiotics after drainage alone for simple abscesses will likely change in the next update of this guideline. But I do want to point out that this was just a 7-day course of antibiotics. So in practice, we've seen a lot of 10, 14-day antibiotics after abscess drainage. I think that's really not necessary. So 7 days was used in this trial. At Denver Health, we actually advocate for a 5-day course of antibiotic therapy. All right. Next case. So this is a 31-year-old healthy woman, presents with 3 days of dysuria associated with fever, flank pain, and nausea. So you diagnose her clinically with acute pyelonephritis and prescribe a 5-day course of levofloxacin. However, the urine culture that you order ultimately grows E. coli that's resistant to levofloxacin. So you call the patient, and she's doing okay clinically, but she's still symptomatic, and so clearly you opt to change her antibiotics. So you decide to change her antibiotics based on her susceptibility pattern to ceftonir, an oral 3rd-generation cephalosporin. So what would be the most appropriate duration of therapy that you would prescribe in this case now, prescribing ceftonir? 5, 7, 10, or 21 days? All right. So most of you, seeing a pattern here, picked 5 days. 3 picked 10 days. And actually the answer in this case is 10 days. So I tried to be tricky here because I couldn't have 5 days for every answer, or you guys would fall asleep even though I was trying to do audience response. And so beta-lactams tend not to work as well for pyelonephritis. And so longer durations of therapy are recommended for beta-lactams. So this is what's said in the IDSA guideline about beta-lactams treating acute pyelonephritis. So oral beta-lactams are less effective than other available agents for pyelo. They go on to say that if you're going to use an oral beta-lactam, you should give an initial IV dose of a long-acting antibiotic like ceftriaxone or aminoglycoside. In clinical practice, I rarely see that done. But they go on to say that the data are insufficient to modify the previous recommendation of a duration of therapy of 10 to 14 days for the treatment of pyelo. So beta-lactams don't work as well as fluoroquinolones or other agents for pyelo. So you do need to extend treatment courses in that particular setting. We recommend 10 days at Denver Health. In contrast, Fluoroquinolones, short courses of fluoroquinolones were great for pyelonephritis. So this is one of the original studies that showed this. So this was over 600 patients with complicated UTI or pyelo that got randomized to 5 days of levofloxacin or a 10-day course of ciprofloxacin. And you can see that really clinical outcomes were very similar in the two groups with respect to microbiological eradication and with respect to clinical success rate. So 83% versus 97 or 79%. So not statistically significant differences. So 5-day course of levofloxacin works very well for pyelo. So it is important to remember that the recommended duration of antibiotic therapy for pyelonephritis does vary by agent, and I've summarized the current IDSA guideline recommendations for you on this slide. So as we've talked about, 10 to 14 days for an oral beta-lactam. Currently, 14 days are recommended for oral trimethoprim sulfamethoxazole or Bactrim. 7 days for Cipro and 5 days for levofloxacin. It's not clear to me why we would need 7 days of Cipro when 5 days of Levo work, but one trial of 7 versus 14 days of Cipro was done, and so I suspect they just included 7 days because that's the dose that was studied. But I think 5 days of ciprofloxacin should work just fine. So certainly something to be aware of clinically in your practice. With respect to this recommended duration of therapy of 14 days for Bactrim, so there was this recent study that came out, and I'm not going to go into this in detail, and this was a retrospective study, but they looked at compared 7-day courses of Bactrim with those who got 7-day courses of ciprofloxacin, which we know is a first-line recommendation for pyelonephritis. And the patients that got 7-day courses of Bactrim did just as well as the patients that got the ciprofloxacin. Again, this was a retrospective study, so it doesn't prove that they're equivalent, but was interesting nonetheless. So we kind of split the difference at Denver Health. We recommend 10 days of trimethoprim sulfamethoxazole, and as I mentioned, 10 days of an oral beta-lactam as well. I also just wanted to point out this paper that's going to be upcoming that hasn't been published yet, but this was presented at one of the European ID conferences earlier this year. So this was a large randomized trial of 7 versus 14 days of antibiotics for gram-negative bacteremia. And so most of these were E. coli bacteremias. Most of them were from urinary tract infections. And in this study, providers were able to pick whatever antibiotic they wanted or whatever they felt like was appropriate based on susceptibilities of the pathogen and the clinical scenario. And so this was a large study. Over 600 patients were included in this study, and nearly equivalent cure rates with 7 versus 14 days of antibiotics, even for gram-negative bacteremia. So the message here is that even there's really no clear indication to extend durations of therapy, even, for example, your patient with pyelonephritis who might be bacteremic. And a number of the randomized trials of quinolones that I've talked about included patients that were bacteremic, so up to 20% of patients were bacteremic in those trials. So very interesting. We'll look forward to seeing this come out in print, but I think a fascinating study that suggests that we really don't need to be treating bacteremias longer, because I think that's something that does tend to be something that prompts providers to use longer treatment courses. So this will be our last case. This is a 62-year-old who presents complaining of 3 days of left lower quadrant abdominal pain and diarrhea. He is febrile and has hyperactive bowel sounds on exam and left lower quadrant tenderness, but no rebound or guarding. He's got a CT that's consistent with acute sigmoid diverticulitis, and there's no perforation or abscess on this. And so the question is, what is the most appropriate duration of therapy, or what is the shortest effective duration of therapy in this particular scenario? So no antibiotics, 5 days, 7 days, or 10 days. All right, interesting. So 10 of you actually would have not given any antibiotic therapy. The majority, though, would say 7 days of antibiotics, and then fewer would say 5 days of antibiotics. So I think for boards, those of you taking boards in the next couple of years, I think the correct answer is, in fact, going to be no antibiotic therapy is necessary. However, if you do prescribe an antibiotic, 5 days of antibiotics does appear to be effective in studies. And we'll talk a little bit more about this concept of why antibiotic therapy may not be necessary at all. So this was a large randomized trial, one of 2 large randomized trials that have come out relatively recently, looking at antibiotics versus just observation alone for patients hospitalized with acute diverticulitis. So this was over 500 patients with a first episode of left-sided diverticulitis, uncomplicated, so these were not patients with abscess or perforation or fistula. So they got randomized to either being watched in the hospital, supportive care, or 10 days of antibiotics, so starting with IV antibiotics and then stepping down to oral antibiotics. And this figure shows recovery out to 6 months, this Kaplan-Meier curve. So the y-axis is actually the proportion of participants without recovery. So it's sort of a double negative, but the lower the better here, the more patients that have recovered. But you can see that observation being the pink line, antibiotics being the dashed blue line, how closely they track over 6 months. So antibiotics really didn't appear to provide a large incremental benefit over observation alone. And the theory here, the hypothesis, is that acute diverticulitis is sort of a segmental inflammatory bowel disease, that it doesn't start out as an infectious process. But ultimately, with breakdown of the bowel mucosa, bacteria can invade the colon and lead to infection and cause things like perforation and abscess and so forth. So these authors actually, this was 6 months of follow-up, studied these patients out to 24 months of follow-up, so out to 2 years, and they had a very high follow-up rate in this population. And out to 24 months, they found no significant differences in the rates of recurrent diverticulitis, complicated diverticulitis, or sigmoid resection. However, there was a numerically higher proportion of sigmoid resections in those that got observation as opposed to antibiotics. And so this has concerned some people a little bit. However, this was only one of 2 trials, and the other trial did not show this trend. And so in summary, these 2 trials, I think, nicely showed that there's not a clear benefit to improving outcomes in patients with acute uncomplicated left-sided diverticulitis with antibiotics. But there have been other studies that have compared durations of therapy and short durations of therapy. One trial was 4 versus 7 or 4 versus 10. I can't remember off the top of my head. But the patients that got 4 days of therapy did just as well as the patients got longer courses of therapy. So if you're going to continue to prescribe antibiotics, which I think this really hasn't caught on in the U.S. yet, but I expect over time you'll be hearing more and more about this, and more providers may be doing this. You may be seeing providers in practice that get discharged from the ED with no antibiotics, so I think important to be aware of. And I also wonder if this could have some diagnostic implications for those of you that do primary care. If you see a patient with mild left lower quadrant pain in your office setting, you might not feel quite the need to send them to the emergency department for a CAT scan if they look well, knowing that the vast majority of these patients do very well with no antibiotics. So perhaps may not need to lose as much sleep at night. So I think you'll hear more and more about this, but I think for the purposes of boards, there's a lot of good evidence that suggests that no clear benefit of antibiotics from a statistical perspective. So I've sort of summarized for you here the common infections that you might see in both the outpatient and inpatient setting, for which short courses, in short I would define as a 5 to 7 day course of antibiotics, are effective. And again, with the caveat here that being the current recommendation for skin abscesses is drainage alone, but I think we're going to see that this has changed to likely a 5 or 7 day course of antibiotic. So that being said, I think there's a key question of, is shorter always better? Are there situations where we know that longer durations of therapy are better, and what are those? From a conceptual standpoint, here are some scenarios where we would not treat for a short course. So if the patient isn't responding appropriately, if you've got a patient you're treating for pneumonia and they're still febrile on day 5, you're probably not going to stop antibiotics at that point. You should be questioning, do you have the right diagnosis? Do they have a complication from that infection? Do they have a resistant pathogen? But that's certainly not a time you'd think about short course therapy. Complicated infections or deep space infections, so pneumonia with a pleural space infection or pyelonephritis with a renal abscess, obviously are probably not going to be candidates for shorter durations of therapy. Immunocompromise, they certainly, these patients don't have the benefit of their own immune system kicking in and helping treat these infections. And a lot of these immunocompromised patients are excluded from studies of duration of therapy. So we really don't know if short courses of therapy work well in immunocompromised patients. And then things like biofilms, slowly dividing organisms, so syphilis and TB are 2 classic examples where you really tend to need longer durations of therapy to treat these. And then lastly, if the antibiotic just doesn't get to the site of infection well that we're treating, so prostatitis being one example. So part of the reason why we recommend more extended durations of therapy for an infection like prostatitis. So I want to just give a specific example for those of you that are perhaps in family medicine or in other settings where you see pediatric patients. So this was a randomized trial that I think is worth being aware of duration of therapy for acute otitis media in young kids. So this was over 500 patients that were less than 2 years of age, so 6 to 23 months of age. They were randomized to receive either 5 days or 10 days of amoxicillin clavulanic acid. And clinical failure, which they defined as either worsening otoscopic signs of infection or failure of resolution or near resolution of symptoms, and that's based on symptom diaries that the parents were filling out. You can see that there was more than double the clinical failure rate in the 5-day group as compared with the 10-day group. And so perhaps in this population where they have waning immunity, waning maternal immunity, and haven't been exposed to these infections, a longer duration of therapy does appear to be more effective in this group. And interestingly, there were no difference in recurrence rates over the long term, antibiotic-related adverse events, or nasopharyngeal colonization with penicillin-resistant pathogens, at least in this relatively small. Short courses of antibiotic therapy are not recommended. The first 2 we've talked about, so acute pyelo, treated with beta-lactams or trimethoprim sulfa, acute otitis media in young kids. Group A strep pharyngitis, so older randomized trials from the 80s suggested higher recurrence rates and microbiologic failure with shorter courses of therapy as compared with 10-day courses. So unfortunately, seems like we're going to be stuck with our 10-day courses of treatment for group A strep pharyngitis. C. diff, a spore-forming infection, H. pylori, all require at least 10-day courses of therapy. And for those of you who do inpatient medicine, I just want to make sure to throw in Staph aureus bacteremia to make sure that everybody's aware that treats Staph aureus bacteremia. The established minimum duration of treatment for Staph aureus bacteremia is 14 days. So we don't treat those shorter. So just as far as some take-home messages, so I think for the vast majority of infections that you're going to see in clinical practice, both in the outpatient setting and in the inpatient setting, 5 to 7 day durations of antibiotic therapy are very appropriate, and in fact 5 days for the majority of these. And we've talked about most of these, so I won't read those off. And then I hope I've convinced you that if we can shift our treatment durations incrementally, that we can really make a large impact on antibiotic exposure, both for our patients and on a population level. So I would propose that we all reset our treatment duration to 5 days of therapy in practice. And so if you're prescribing 5 days for most infections, maybe 7 days sometimes, you should really be asking yourself when you're prescribing 10 days or longer, is there really a good reason for this extended antibiotic course of 10 days or longer? And there may be, but the point is to know some of those exceptions where longer durations are appropriate. And if you're not dealing with one of those exceptions, Stick to the shorter course. And I'd also caution all of us not to practice anecdotal medicine. So you may prescribe a patient with cellulitis 5 days of antibiotic treatment. And that cellulitis might get worse and that patient may need to get hospitalized. But the science, the trials suggest that the likelihood of that happening is the same as if you gave that patient a 10-day course of antibiotics. So don't let single events color your practice. We really need to be practicing based on what we know the clinical trials have showed us. So just as we're ending here, I just wanted to point out two very interesting editorials published in the last couple of years. The first is talking about the antibiotic course. So remember how the message always used to be we would tell our patients, you have to finish your antibiotic course, and if you don't, you're putting yourself for developing antibiotic resistance. Well, that really is starting to fly in the face of everything that we have learned in the recent decades, that shorter courses of antibiotics really are better and actually probably do lead to less of a risk of antibiotics. So an interesting editorial if you're interested in reading about that. And then another one by Brad Spellberg entitled The New Antibiotic Mantra, Shorter is Better. So the last question will just be an exit poll, and we know from politics that exit polls are historically inaccurate, but the durations that you prescribe, will those change at all? Will they change? Will they be shorter, or will they be longer going forward in clinical practice? Let's get to Kahoot. All right. So many of you suggest that you will actually go forward prescribing shorter courses. So I feel like I've maybe done my job here. Thankfully, nobody said that they would start prescribing longer durations, in which case I would have to go back and reevaluate the talk. All right. So the last slide is just for fun. So this is a movie quote. I'm too short and I'm not no good. Who said this and what movie was it? It's an older movie. Does this ring a bell for anybody? What? Hoosiers, yeah. So this is Ollie from Hoosiers. So who else said this? The 5-day course of doxycycline. But what do we know? So Ollie sinks 2 free throws at the end, underhanded free throws at the end of the game to win the playoff game, one of the playoff games for his team. And we know that 5-day courses of doxycycline work really well for a lot of infections, pneumonia, bronchitis, skin infections. So go forth and prescribe short courses of antibiotics. And I thank you all for your attention in the last talk of the day. And I'm happy to take any questions or comments if you have any. And I'll also be here for a minute or two afterwards if you want to come up and talk. Thank you.